Ladies and gentlemen, Global Health and Welfare Forum in Taiwan 2025 is about to begin in 5 minutes. You may start to take your seats and kindly silence your phones. You may also scan the QR code on your badge to have a look at the program book this year. Thank you very much. 提醒各位贵宾，我们大会呢，再过5分钟之后，即将就要正式开始了，请您准备就座，并且记得将手机转为震动或静音。都欢迎各位贵宾呢，可以扫描您识别证上的 QR code， 就可以看到线上的大会手册。那也提醒有需要公务人员时数的贵宾呢，请记得每天都要签到以及签退，谢谢。 Ladies and gentlemen, we're going to begin in 1 minute. Please take your seats right now. Thank you very much. 各位贵宾，我们大会呢，再过1分钟之后就要正式开始了，请您现在就坐，谢谢。 Ladies and gentlemen, good morning. Yes, welcome to Global Health and Welfare Forum in Taiwan 2025. Taiwan National Health Insurance at 30 towards sustainable success in the 21st century. 欢迎各位现场贵宾莅临2025年台湾全球健康福祉论坛台湾健保30年共创永续未来. Yes, this year marks the 30th anniversary of Taiwan's national health insurance. We're very excited, very thrilled, and very happy to be joined by so many distinguished guests, friends, and partners from around the world to celebrate this milestone moment. 没错，今年大会呢也适逢台湾健保30周年，非常荣幸为大家邀请到来自于全世界各地的贵宾、伙伴以及好朋友们共襄盛举哦，共聚一堂来庆祝这个重要时刻。And now to begin, ladies and gentlemen, we have a very special opening performance for you. It's a combination of drum performance and sand art, okay? 那接下来呢，我们首先准备了一段非常别开生面的开场演出哦，要邀请石鼓集乐团以及插画艺术家 Mario 为大家带来精彩的开场演出，同时呢，为2天的大会揭开序幕。All right, ladies and gentlemen, please welcome 10 Drum， 让我们掌声欢迎石鼓集乐团。 谢谢石鼓，以气势磅礴的鼓乐，为2025年台湾全球健康福祉论坛揭开序幕。接下来，我们要透过沙画的表演，来回顾，同时展望台湾健保30年的过去、现在以及未来。Next, we're going to walk you through the past, present, and future of Taiwan's national health insurance. In the 1980s, as Taiwan's economy began to soar, insurance existed for workers, farmers, and public servants. Yet many people were still left unprotected, and illness could easily lead to poverty. After years of government research and planning, Taiwan launched the National Health Insurance Program in 1995, achieving Universal Health Coverage, UHC, for all. It ended the vicious cycle where illness led to poverty, and poverty led to illness. The spirit of social solidarity in national health insurance ensures that patients with major or rare diseases receive proper support. Those facing financial hardship can also find help through the NHI Charity Fund. In Taiwan's mountain and offshore areas, medical teams reach remote communities through local clinics and mobile services. recent years, telemedicine, connecting doctors and patients through video, has brought healthcare resources even farther. With the Rural Health Program, medical staff are now stationed in underserved areas, ensuring that quality care reaches every corner of the island. Building on the foundation of national health insurance, we're moving toward greater health equity and sustainable development. For people, the environment, and the society. Through smart healthcare, we aim to enhance quality and efficiency, making NHI a vital force for a stable and sustainable future. Declining birth rates and aging populations are challenges shared by many nations, with people at the heart of our mission, which strive to provide appropriate, continuous care from the beginning to the end of life. Together, we safeguard the sustainability of Taiwan's health insurance, healthcare, and finances, building a healthy home for all. The story of national health insurance goes on with care, innovation, and hope, lighting the path forward. "30 years of national health insurance, a journey to look back on and a new beginning for the future." Ladies and gentlemen, put your hands together for Taiwan's National Health Insurance at 30, and also the grand opening of Global Health and Welfare Forum in Taiwan 2025. 我们再次谢谢石鼓以及插画家 Mario 带来非常精彩的演出，让我们看到台湾健保30年它一路的历程哦。那同时呢，也为我们2天的大会正式的揭开序幕。And now, ladies and gentlemen, to welcome you all and to give you the opening performance, please join me in welcoming Dr. Chong Liang Shi, Ministry of Health and Welfare, ROC Taiwan, to the stage. 接下来我们掌声欢迎主办单位卫生福利部石崇良部长上台开场致辞，有请部长。
Our Honorable former Vice President Chen Jianren, Honorable Health Minister, Vice Minister, Excellencies, Ambassadors and Representatives, distinguished guests, experts, ladies and gentlemen, good morning.
Morning.
It's our great pleasure to join you all for the 2025 Global Health and Welfare Forum in Taiwan. I would like to begin by extending a special welcome to our international guests who have traveled so far to join us. I would also like to thank our domestic and global partners for your long-standing dedication and unwavering contribution to public health. Taiwan continues to make strides in public health, medical services, and social welfare. We also work hand in hand with partners around the globe to provide humanitarian medical aid, prevent infectious disease, care for those with rare ailments, and share our experience with palliative and hospice care. Moreover, we are learning from others as we optimize our national health insurance program and introduce the innovative, smart medical technologies here in Taiwan. Taiwan's national health insurance coverage rate exceeds the 99%. Moreover, the program has earned international accolades since its inception. In the 2025 Nobel Healthcare Index, Taiwan scored 86.5 and was named the world's best healthcare system for the 7th consecutive year. This achievement is the result of the tireless collaboration of experts, medical personnel, and government departments. However, facing an aging population, declining birth rates, and the financial pressure on the health insurance system, as well as the workforce shortage and the rapid advance of the medical technology and artificial intelligence. Our next mission is to further advance the health and the well-being of our people and improve the working environment for healthcare workers, all while ensuring financial sustainability. Today, we are honored to welcome all distinguished experts from the United States, United Kingdom, Europe, Japan, Korea, and many countries. During the meetings, we will focus on such pressing topics as promoting global health and sustainable welfare, advancing health equity, and facilitating the sustainable development of the national health insurance system. Through in-depth exchanges and discussions, we hope to identify actionable solutions as we continue to work on the NHI program, while also sharing insights and contributions useful for public health system and the world. So I wish the 2025 Global Forum in Taiwan great success and fruitful result. Thank you so much.
Thank you very much to Dr. Chongliang Shi, Minister of Health and Welfare, ROC Taiwan. Thank you very much. You may return to your seat first. 我们非常谢谢卫生福利部施崇良部长的开场致辞哦。And just like Minister Shu just pointed out that our Global Health and Welfare Forum over the years has become one of the most important platforms for experts and also health ministers around the world to exchange ideas. And indeed, coming into its 21st year, the Global Health and Welfare Forum has become one of Asia's most important public health events. And each and every year, we are so very happy to be joined by health ministers, senior health officials, experts, and NGO representatives joining us. Thank you so much for your support and participation. 没错，从2005年举办第一届以来哦，全球卫生健康福祉论坛呢，已经进入了第21届。 那俨然成为亚洲最重要的公共卫生的盛会之一。每年呢，都有许多的卫生专家共同来与会讨论重要的议题。And now, ladies and gentlemen, next we come to the most important part of our opening ceremony, group photo. All right. 那接下来呢，我们要邀请我们每年呢从世界各地共同来共襄盛举的贵宾上台来一起合影哦。我们首先有请唱名道的贵宾呢在第一排来就座。And if you hear your names, please take your seats on the stage. 我们首先呢要再次掌声有请卫生福利部石崇良部长 ，Please welcome once again Minister 崇良 Shu of Health and Welfare, ROC Taiwan to the stage. 有请。接下来呢，我们要有请中央研究院陈建仁院士。Next, please welcome Jen Chen, Academician, Academia Sinica, ROC Taiwan to also join us on the stage. 接下来我们要欢迎的是外交部陈明奇政务次长。Next, please welcome Ming-Chi Chen, Deputy Minister, Ministry of Foreign Affairs, ROC Taiwan. 有请。And next, we'd like to welcome Kevin Bernard, the Minister of Health and Wellness, Belize. 接下来我们有请贝里斯卫生部长。也请您到台上来，共同加入合照的行列。有请贝里斯卫生部长。And also this morning, we are very happy to be joined by Munduduzi Matsebula, Minister of Health, Kingdom of Eswatini. 接下来我们要有请史瓦蒂尼王国卫生部长也到台上来，一起加入合影。有请。And next, we'd like to welcome Joaquin Banoya, Minister of Public Health and Social Assistance, Republic of Guatemala. 接下来我们有请瓜地马拉卫生部部长，我们也到台上来就座，准备一起合照。Next, we'd like to welcome Becton Sinon, Minister of Public Health and Population, Republic of Haiti. 接下来我们欢迎的是海地共和国卫生部长，我们到台上来一起合影。Also joining us today, we have Ota Kisino, Minister of Health and Human Services, Republic of the Marshall Islands. 接下来我们有请马绍尔群岛共和国卫生部长也到台上来。Next, we'd like to welcome Tuafafa Latasi, Minister of Health and Social Welfare, Tuvalu. 接下来我们邀请贵宾图瓦鲁卫生部长，我们也到台上来就座。Next, we'd like to welcome Nerissa Gittens, Permanent Secretary, Ministry of Health, Wellness and the Environment, Saint Vincent and the Grenadines. 接下来我们有请圣文森及格瑞纳丁卫生部次长到台上来一起合影。接下来呢，我们有请卫生福利部中央健康保险署陈亮瑜署长。Next, please welcome Liang Yuchen, Director General, National Health Insurance Administration, Ministry of Health and Welfare, ROC Taiwan. All right, next joining us, we have Edgar Gonzalez, Deputy Minister of Public Health and Social Assistance, Republic of Guatemala. 接下来呢，我们要邀请瓜地马拉卫生部的次长，有请。And Jenny Daniel, Permanent Secretary, Ministry of Health, Wellness and Elderly Affairs, Saint Lucia. 接下来我们邀请圣露西亚卫生部次长也到台上来。Hector Dami, Head of the Department of Academic Informatics, Faculty of Medicine, National University of Asunción, Paraguay. 接下来我们有请巴拉圭亚松森大学医学院附设医院学术资讯主任，有请。And Natano Elisala, Deputy Secretary, Ministry of Health and Social Welfare from Tuvalu. 接下来我们邀请图瓦鲁卫生部副次长。And next, we'd like to welcome William Qinglun Xiao, KT Lee Professor of Economics Emeritus, Harvard T.H. Chan School of Public Health, USA. 接下来我们邀请我们的主讲人，哈佛大学陈增熙公共卫生学院李国鼎荣誉经济学萧庆伦教授。And joining us next, we have Irachiso Meko, Chief of Medical Services, Bureau of Hospital Services, Ministry of Health and Human Services Republic of Palau。接下来我们欢迎帛琉卫生医疗服务处的处长。接下来呢，我们唱名到的贵宾要请您站在我们座椅后方的正中间哦，有请我们的工作人员引导。我们首先呢，要有请国立成功大学医学院名誉教授陈志宏院长。Next, we'd like to welcome 志宏 Chen, Professor Emeritus, National 成功 University, ROC Taiwan。接下来我们邀请的是普林斯顿大学公共与国际事务学院卫生政策郑宗美研究员 and 宗美正 Health Policy Research Analyst, Princeton School of Public and International Affairs, Princeton University, USA. Please also join us on the stage. And we'll also next we'd like to welcome Martin McKee, Professor of European Public Health, London School of Hygiene and Tropical Medicine.UK， 接下来我们邀请的是伦敦卫生与热带医学院欧洲公共卫生教授，有请。Okay, you may take your seats right now. 我们请第一排的贵宾可以先就座了，没有关系哦。Okay, ladies and gentlemen, next we're going to do it, inviting our distinguished guests to the stage in 6 rounds. Okay, according to your sections you're sitting. All right, we have a lot of guests.Joining us today. 接下来呢，我们依照这个梯次邀请贵宾到台上来哦。Firstly, ambassadors and representatives of foreign missions in Taiwan sitting in Section D. 首先，我们有请坐在 D 区第2、3排的驻台使节。我们请跟随工作人员引导。Please follow the instructions of our staff to the stage. 我们请您站在阶梯的第3排右侧。Please stand on the 3rd row of the stand.On your right-hand side. Thank you very much. 有请。好，我们邀请我们的贵宾呢依序的上台哦。那接下来呢，我们要邀请的是我们 A 区第2、3排的驻台使节。我们请工作人员也协助引导到台上来，请站在阶梯第3排、第2排的左侧。And also ambassadors and representatives of foreign missions in Taiwan.Please also join us on the stage. 接下来呢，我们要有请在 CD 区第3排的主持人以及讲者。Next, we'd like to welcome moderators and speakers sitting in section C and also D. Please follow the directions of our staff. 我们请您站在阶梯第3排、第2排的右侧，有请。接下来呢，我们继续邀请主持人以及讲者到台上来哦。我们邀请坐在 B 区第3排的主持人以及讲者，我们请站在阶梯第1排的正中间。And we continue to invite our moderators and speakers sitting in section B. Please stand in the middle of the first row. 有请。接下来呢，我们继续邀请主持人以及讲者 C 区第2排。我们请工作人员协助引导到台上来，请站在阶梯第1排的右侧。All right, moderators and speakers sitting in section C, please also join us on the stage and sit on row 1 on the right-hand side. 以及我们B 区第2排的主持人以及讲者，要请您站在阶梯第1排的左侧。And more moderators and speakers sitting in section B, please stand on the left-hand side of row 1. 好的，那今天呢也非常荣幸有许多的国外官员一同与会哦。接下来呢，我们就一同来邀请坐在 A 区以及 D 区第1排的国外官员，我们到台上来，请在座位区的后面，我们阶梯的前方哦。我们请站到合照的位置。And lastly, we'd like to welcome foreign government officials and delegates. Please stand behind the chairs on the stage. 好，邀请我们的贵宾到台上来。Please join us on the stage for the group photo of 2025 Global Health and Welfare Forum in Taiwan. Okay, just to make sure that we're not missing anyone here. 我们贵宾都有在台上来吗？ 有没有？我们要再加人的都还可以 ，OK？ 有吗？沈署长，署长有请 ，OK？ Yes, please join us on the stage. All right. OK. 有吗？啊，部长还在叫人上，还有谁？我们还有贵宾要上台吗？好，那我们请台上的贵宾呢，我们拍3张哦。We'll do 3 shots on the stage. All right? Yes. OK. 我们首先第1张呢，请您拿出您的微笑。For the first one, just a very big smile on your face. All right? And look at the cameras in front of you. Okay, everybody, look at the cameras in front of you first. 3, 2, 1. And then the cameras in the back, okay? 我们后方也有很多的镜头哦。Okay, look at the cameras in the back. 3, 2, 1. Okay, 我们再拍一张哦。One more. 好的，那接下来呢，我们准备了这个手拿牌要给各位贵宾哦。And we also got you hand cards for the group photo, all right? For the second photo on the stage. Yes, we're celebrating the opening of Global Health and Welfare Forum in Taiwan and also 30 years of Taiwan's national health insurance. Yes, show us the hand cards. 把这个手拿牌秀出来。All right, everybody, look at the cameras in front of you first. 3, 2, 1. And the cameras in the back. 好，我们后方的镜头也请看一下哦。Everybody? Okay, 3, 2, 1. 都有拍到吗？ Okay, last one on the stage. Yeah, we want you to do this OK pose, also the 30 years pose for Taiwan National Health Insurance, everybody. Yes, do this to celebrate the 30th anniversary of Taiwan's National Health Insurance. Everybody, look at the cameras in front of you first. 3, 2, 1. All right, more cameras in the back. In the middle first. 先看上中间。3, 2, 1. And then to your right. 看向右边。To your right. 3, 2, 1. And then to your left. 看向左边。3, 2, 1. And I promise you the last one. To the middle again, okay? 最后再回到中间再拍一张。3, 2, 1. 我们再次给台上的所有的贵宾一个掌声。Give all of our distinguished guests on the stage another big round of applause. Thank you so much. You may return to your seats. Thank you so much. 谢谢我们台上的所有的各位贵宾哦，包括了有驻台使节以及我们的主持人、我们的主讲人，那同时呢还有来自于世界各地各国的卫生官员。Thank you once again to all our distinguished guests joining us for the group photo, including ambassadors, representatives of foreign missions in Taiwan, moderators and speakers, and foreign government officials and delegates. Please return to your seats first. 我们请各位贵宾回座之后呢 we are not done with group photos. Okay, we're going to take one more, okay, with our photographers on the stage taking a photo of all of you joining us for the 2025 Global Health and Welfare Forum. 好，我们请摄影师呢到舞台上哦，帮我们今天参加2025年台湾全球健康福祉论坛的所有贵宾再拍一张大合照。好的，这个机会很难得，不好意思哦，我们花比较多的时间在拍合照哦，但这对我们来说呢，真的非常别具意义哦。All right, everybody, please return to your seats first. We would like to take one more photo, all right? Okay. You're all set for the group photo, all right? 有手拿牌的帮我们秀出来哦。If you have hand cards, please show the hand cards. And for other people, you know what to do? Do this 30 years pose, okay? All right, everybody? Okay. Look at our photographers on the stage. 好，我们看向我们舞台上方大会摄影师的镜头 ，OK? Please look at him. 3, 2, 1. Okay, one more. 3, 2, 1. Okay, one last one, okay? Okay, one last one. 好，我们大会摄影师、官方摄影师再拍一张哦。Okay, everybody, 3, 2, 1. 谢谢，我们给自己一个掌声好吗？ Give yourselves a big round of applause. All right, that's it for the group photo. Okay, and some of you are already tired. We're sorry about that, okay? Yes. But we really appreciate this very, very precious moment to spend time with you, walking through some of the most important public health issues in the world. And that's what we're going to do for this 2 days. We're going to have 1 keynote session, 3 plenary, 4 parallel sessions, joined by 9 moderators, 33 speakers from the US, the UK, Europe, including Poland, Switzerland, Belgium, France, Germany, Korea, Japan, and of course, Taiwan。 没错，我们接下来2天大会的议程非常的丰富，非常的精彩哦。总共安排了有1个场次的专题演讲，3场的大会场次，4场的平行场次，总共呢邀请到9位主持人以及33位来自于美国、英国、欧洲、波兰、瑞士、比利时、法国、德国、韩国、日本，当然还有来自于台湾的专家来共同与会哦。All right, and now, ladies and gentlemen, we move on to the keynote speech session. 那接下来呢，就是我们主题演讲的场次了。We're going to focus on how to advance global health and sustainable well-being, promoting health equity. 我们的主题呢是推广全球健康以及永续福祉，促进健康公平。And now to open the session and introduce your keynote speakers. Ladies and gentlemen, please welcome your moderator, Professor Jianren Chen, academician and distinguished professor of Genomics Research Center Academia, Seneca, ROC, Taiwan. 让我们掌声欢迎专题演讲场次的主持人，中央研究院院士、基因体研究中心特聘研究员陈建仁院士。
Minister Shu, a lot of ministers here, and distinguished invited speaker, ladies and gentlemen, good morning, everyone. I'm very honored to be the moderator of the keynote speeches. The theme of this forum of this year focus on Taiwan National Health Insurance at 30 toward sustainable success in the 21st century. Taiwan's national health insurance system is recognized as one of the most successful models worldwide. However, confronted by the rapidly aging population, geopolitical instability, and the opportunities and challenges presented by emerging digital technologies, we must carefully consider how to ensure the resilience, equity, and sustainability of our health system. The advancement of global health and well-being is a critical issue facing the international community today. Following the COVID-19 pandemic, global health challenges extend beyond infectious diseases, with chronic conditions and health inequality remain severe problems. The core objective of advancing health equity is to ensure that everyone, regardless of socioeconomic status, geographical location, or ethnic background, has access to fair, accessible, and high-quality medical care. This is the fundamental basis for achieving sustainable well-being. It requires multinational cooperation, cross-sector coordination, and innovative policy frameworks to address rapidly evolving health needs and the complex challenges faced by global society. We profoundly honored to have international renowned experts to deliver keynote speeches at this forum. I would like to welcome our first speaker, Dr. Shi Liang, the Minister of Taiwan's Ministry of Health and Welfare, with over 15 years of leadership experience in various key roles, including Director General of the National Health Insurance Administration and Deputy Minister of Health and Welfare. Dr. Shi is a recognized expert in health policy, emergency medicine, and public health. He has played a pivotal role in shaping Taiwan's healthcare system, notably during the COVID-19 pandemic, where he led the medical response division of our Central Epidemic Command Center. Dr. Shi has been honored with Taiwan's prestigious Order of Brilliant Stars for his outstanding public services. Now, let us welcome Dr. Shi to give the keynote speech.
Thank you, Chairman, Professor Chen's so kind introduction. Distinguished guests, colleagues, friends, good morning. It's my great honor to celebrate the 30th anniversary of Taiwan's National Health Insurance with you today. Over the past 3 decades, Taiwan's national health insurance has developed from an idea into a global non-missed model. And I want to thank the dedication of the countless healthcare workers. Today, national health insurance programs serve as the foundation of the social stability and the prosperity. However, the challenge remained, just the Professor Chen mentioned. So today, I want to share the Taiwan's efforts in health insurance reform and how we are addressing the future challenges to build a sustainable healthcare system. So here is the outline of today's presentation. I will talk about the achievements and the impact of the national health insurance over the past 30 years first, followed by the healthcare challenges and NHI reform in Taiwan. So firstly, let us review the history of the Taiwan National Health Insurance. In 1950, labor insurance covered about 40% of the population, followed by government employee insurance and farmer insurance. By 1994, only 60% of the population was covered, with children and the elderly being the most effective. In 1995, the National Health Insurance expanded the coverage to the entire population, including foreign residents in Taiwan. Today, NHI ensures the comprehensive health care access for all residents in Taiwan. So now let's take a moment to highlight the progress in Taiwan's health over the years. When the national health insurance was introduced in 1995, the life expectancy for men was about 71.9 years, while for women it was 77.7 years. Fast forward to 2025, we can see the significant improve. It reflects an increase about 6 years for men and 7 years for women. So today, Taiwan's life expectancy not only exceeds the global average, but is also projected to increase continuously. So one of the core value of the Taiwan National Health Insurance System is eliminating financial barriers to health care. So according to 2018 data, the NHI benefit ratio is about 1.1, with the lowest income group receiving the highest benefits at 2.1. As income increases, the benefit ratio decreases, reaching 0.8 for the highest income group. So it shows the national health insurance system shares the burden of healthcare costs, making healthcare more affordable, particularly for low-income families. Additionally, through the NHI, we ensure that the even highly expensive treatments are accessible to all. For instance, the medical cost for hemophilia patients can be up to 82 times higher than the average, but are fully covered by NHI, preventing the financial hardship for affected family. Furthermore, Taiwan's national health insurance has consistently increased the investment in new drugs and the treatments for rare disease. For 2025, the budget for new drug-related expenses will reach 1 billion NT dollars, with 5 billion NT dollars specially set aside for the cancer drug fund. On the top of that, the special fund for rare disease and hemophilia treatments will grow to 1.8 billion NT dollars, which is a 19% increase from 2024. In 2024, the budget for new medical technology changes in reimbursement regulations, and the provisional payment will about 6 billion NT dollars, which is roughly doubled what we spent in 2023. So this showed our system supports patients with serious illness, providing access to the latest treatment. So however, like all the developed countries, we also face the challenges. One of the most critical issues is the aging. Taiwan officially become a super age society in 2025. This brings an increased burden, especially from chronic disease like hypertension, diabetes, and cancer. At the same time, the new medical technologies are advancing rapidly, offering better treatment options, but they also add pressure to our healthcare system finance. So moreover, with the low birth rate, these challenges threaten the long-term sustainability of our health system, highlighting the need for more integrated and efficient models of care. So chronic disease, especially the three highs, hyperlipidemia, hyperglycemia, hyperlipidemia, are major health concerns in Taiwan. These conditions not only affected millions of people, but also lead to serious health complications like the cardiovascular disease and the renal failure. In the 2024, these diseases are expected to impact over 8.5 million people, or 37% of the Taiwan's population, as well as account for 40% of the total NHI expenditure. So this highlights how critical it is to address this disease effectively, both to promote health equity and to ensure the long-term sustainability of our healthcare system. Cancer is another top issue. It has been the #1 cause of death in Taiwan for consecutive 43 years in a row. This chart shows the trends in death rate from the top 10 cancer in Taiwan. As you can see, the lung cancer and the liver cancers are still the leading cause of the cancer deaths. However, the death rate have been going down in recent years. But for some cancers like the breast cancer, prostate cancer, pancreatic cancer, death rates are still increasing. So this shows that we need to keep the focusing on these cancers. Since NHI was launched, the breakdown between the outpatient and the inpatient cost has stayed relatively steady. This outpatient care making up about 65% and the inpatient care 35%. However, the number of the outpatient visits has been going up, with people expected to visit the doctor 16 times a year in 2024. So this increase in visits and the cost has been putting pressure on our healthcare system. So in the past, we focused more on treatment than prevention, but now we are planning to invest more in prevention to lower the unnecessary medical costs and improve public health. So what does the effective healthcare model look like? An effective healthcare model is more than just medical treatment. It has to integrate healthcare with community support and adjust to long-term needs. In this model, patients are empowered and the care teams work proactively, ensuring that the communication is continuous and personalized. So this approach helps improve the outcome for patients with chronic disease and strengthens the resilience of the whole healthcare system. So we conducted the following the NHI reform. Taiwan has the higher rate of the premature deaths due to chronic disease, which has made the chronic disease management a national priority. So President Lai has stressed this goal through the Healthy Taiwan policy, which includes the 3-8 goals. The aim is to have the 80% of the patients in care networks, 80% receive the lifestyle counseling, and that 80% with better control of the metabolic conditions. So NHIA is enhancing the chronic disease management with programs like Family Physician 2.0, holistic care models, and bundled payments. We are also using the digital platform and public-private partnership to improve prevention and the healthcare delivery. So digital tools like the My Health Bank are helping patients manage their health and support the doctors in making a better decision, finally improving the healthcare outcome. So to strengthen the resilience of the system, we have recently introduced a range of the innovative service model. We were rolling up several important programs, including acute care at home, home-based dialysis, home palliative care program, OPAT, ERAS, and etc. So next I will provide more detail on a few of the key initiatives. To provide a safer and more familiar alternative to hospitalization, the NHIA launched the Acute Care at Home program on July last year. This program allowed the care teams to visit the patient at home for services like antibiotics injection, offering an alternative for patients with limited mobility and the residents of the care facilities. So the program, the outcome, initial outcome showed it has saved the cost with average expenses of 30,000 points, lower than the average of usual hospitalization. It has also improved the bed utilization, freezing up about 100 hospital beds daily. To reduce unnecessary hospitalization, we also launched an incentive program for outpatient parenteral antibiotic therapies on August 1st, 2025. The program integrates the inpatient, emergency, and outpatient antibiotic treatment resources to enhance the care access, reduce the hospital admission, and improve the hospital bed turnover. As the shifting 10% of inpatient with infectious disease, we will save $350 million and shorten about 156,000 bed days. To help the patients recover fast after surgery and reduce the complication, NHIA launched the ERAS, Enhanced Recovery After Surgery program, on July 2025. This program starts before surgery and focuses on the patient-centered care maintained throughout the entire process. It is now being carried out by about 100 hospitals nationwide, involving teams made up of surgeons, anesthesiologists, case managers, dietitians, and physical therapists. The goal is to improve the quality of care, shorten hospital stays, and increase the bed turnover rate. Regarding the telemedicine, since the COVID-19 pandemic, telemedicine has developed rapidly. Starting from the 2020, Medicare telemedicine benefit plan has allowed the local physician to provide in-person consultations with remote physicians offering diagnostic and treatment advice via video. This program serves the regions like the mountainous area, remote islands, and underserved regions. Started in August 2025, the telemedicine program will lift the specialty restrictions, expand the services to include the medical stations in underserved areas, and increase the consultation fee surcharges for local institutions. After hospitalization, always have some patients still need the long-term care. So this plan is all about combining medical and the long-term care services. On the service side, our family physician program gives continuous support, covering treatment, home care, and the telemedicine. So we have also set out a community network that connects the long-term care, post-acute care, and the palliative services, helping patients from healthy agents all the way to end-of-life care. On the digital side, we have created a platform to connect healthcare workers across hospitals, homes, and the communities, making it easier to share data and provide the coordinated care. About the cancer is top one of the deaths. We have developed a national strategy for cancer control that covers the whole care process. Our approach focuses on 5 main areas: health promotion and prevention, evidence-based screening, preventive treatment, early diagnosis, and finally precision treatment. A major milestone was the launch of the low-dose CT screening for lung cancer in July 2022, aimed at high-risk groups such as those with family history or heavy smokers. Next year, we will also introduce the nationwide HP screening for gastric cancer. We are also strengthening the precision medicine throughout the patient journey, including genetic testing, targeted therapy, and immunotherapies. This integrated strategy is designed to reduce the cancer risk, detect the cancer earlier, and ensure that the patients receive the right treatment at the right time. One of our main goals in healthcare reform is to strengthen the public self-care. To achieve this, we have created My Health Bank, a platform that brings together medical records, prescription, lab results, and important health data. It includes the information on organ donation, palliative care, cancer screening, and vaccinations. This platform helps people track their health, assess risk, and improve their self-care. We also launched the digital healthcare incentive program, which encouraged the healthcare workers, providers to use digital tools to manage a chronic disease. This tool analyzes the health data, provided personalized health education, and help people manage their condition more effectively. So Taiwan's national health insurance has accumulated 30 years of the claim data, which not only support the payment verification, but also play a role in improving health care quality. So we aim to enhance the value of this data in three main areas. Internal analysis to support the medical reviews and monitor healthcare quality. Public information, it also offers the provider accessible healthcare quality data for the public. Finally, we also can provide the academic site, offer the de-identified data to research purposes. So looking ahead, this healthy Taiwan's goals will guide our plan toward better health for all. To sum up, we aim to raise the life expectancy to 82 years by 2032. This goal reflects our commitment to enhancing the health of the Taiwanese population, but I think it's not an easy job. We also aim to reduce the mortality rate from chronic disease by 1/3 by 2030, focusing on prevention and effective treatment for conditions like hypertension, hyperlipidemia, and diabetes. Lastly, the cancer prevention and the treatment plan seeks to reduce cancer mortality by 1/3 by 2030 through the early screening, precision medicine, and the cancer drug fund. So above the goal, I think all is not easy. But I believe together, this goal will strengthen our healthcare system and ensure the healthier future for all. So thank you all for your patience and attention today. So I truly appreciate your time and hope that your feedback and comment. Thank you so much.
Thank you very much, Dr. Shi, for your excellent presentation. And let's go for that three major goals. I do believe that under your outstanding leadership, we will approach its goal as soon as possible. Now, it is really my tremendous honor to introduce our next speaker, Professor William Hsiao. Professor Hsiao is the KTD Professor of Economics Emeritus at the Harvard T.H. Chan School of Public Health, where he founded and led the Health System Study Program. Professor Hsiao has a deep connection with Taiwan's national health insurance. He once served as the chief advisor of the National Health Insurance Planning Task Force and played a key role in the planning of its first phase. Given that the system has now been in operation for 30 years, inviting him to speak at this event holds even greater significance. So let us warm applause to Professor Hsiao.
Honorable Chair, Professor Chen, and Minister Shu, and distinguished guests, I'm honored and privileged to have a chance to speak to you. And I'm going to actually play the historian, since I say I was a witness at the time of creation of the Taiwan's national health insurance. And I'm going to keep my remark informal, because I'm going to tell some inside stories when we created. And so I'd like to thank Minister Shu, gave us such excellent, comprehensive and detailed explanation of the history and also the current situation and your aspiration for 2032. I hope you accomplish that. But I will keep, I like to actually throw a little bit of excitement to get everybody to think what differently, because I'm going to propose a somewhat different challenge for the intermediate and sustainability of Taiwan's national health insurance. Minister Shu already gave you a very detailed explanation of the achievements. It has been ranked by Nobel and the CEO magazine Healthcare Index as the #1 health system in the world. And Taiwan should be proud of that. That's due to really the hard work of many people right in this audience. And the achievement is already cited, so I won't, there are 99.9% of Taiwanese, including the ones who live in overseas, are covered. So it has good quality care and improve the health outcome of the Taiwanese. And equally surprising, the domestic rating that Taiwan enjoys is consistently 85% of the people who are polled almost every month they said we are happy with our health care and health system and national health insurance. Let me tell you the record in the United States. United States only have 30% of people say we are satisfied, and Taiwan have 85%. So this is a proud record Taiwan has achieved already. Now, I'm sorry, no. Well, you can see I'm technology challenged. I want to give credit to people who really made this possible at the beginning. Subsequently, there were others who really made Taiwan's national health insurance possible. First was the president himself took a strong interest in this. And then he actually pushed his cabinet, eventually passed the law. And he even made a statement, passed the national health insurance law. He offended every doctor in Taiwan. That's in the public record. That's what kind of opposition he faced in 30 years ago. Second is the person who actually directed the planning overall. That's Taiwan's, at that time, he was the vice chair of the Economic Planning Commission. Please notice, the planning was not given to Ministry of Health because there are too many vested interests resting in that. It was given to the highest level Economic Planning Council, who is above the cabinet level. And Vincent Shu, who later became the vice president of Taiwan, he led that commission for this project. Third is, I don't see him in the audience, is really the head of the task force, Yang Zhiliang. And he worked hard, not only during the planning, and also during the legislative process. And last but not least, you can plan and draw a picture, a design on paper, but who is going to build it? Who is going to actually make sure everything's done correctly? And that was Ye Jinchuan. Again, I do not see him in the audience today. So I want to acknowledge all of these people who were there at the original, made it possible. Then there were others, like right now sitting in the back row is Zhang Hongren, who led that and later on introduced the IC identification card and helped by Ye and Liu sitting right there. They are the heroes I want to acknowledge. This is a personal. So, then I'm going to surprise you. I'm going to say Taiwan needs a major restructure of its health system, including which the foundation is national health insurance. And I want to give you 3 major reasons why I'm going to elaborate with a little bit detail of the time given me. One is, in the original design, there were basic flaws. And the basic flaws to this day has not been corrected except through patchwork. That caused problems for Taiwan's national health insurance. Second, we designed the national health insurance 35 years ago. The condition has changed, as Minister Shu pointed out. So what we designed for a different environment, that changed. So you have to change the system. Third, I will argue, in the future, even 10 years from now, not 2032, but 10 years from now, you're going to see we have a new industrial revolution from artificial intelligence, from GAI, from robotics. Minister Shu already pointed out how they use telemedicine. That was never even thought of 20 years ago. Just think, 15 years from now, the world in technology is going to change. And that will change the organization, change our tax system. Like Taiwan's, right now, the industrial assets has shifted to high technology, like Taiwan semiconductor manufacturing. It's not in the small, medium-sized business again. How you tax people, pay the premium for healthcare will change. That has to be planned, ladies and gentlemen. So that's my part. Let me use my role as a historian, explain what we did not do in the original plan. There are 3 reasons, and I would take a few minutes of your valuable time to actually elaborate a little bit. First, Taiwan's payment for doctors and hospitals are outdated. And when we designed it, we knew it was outdated. But because of political opposition by physicians, we were not able to do it, and I will elaborate a little bit later. And that remained with us today, causing some of the fundamental problems in Taiwan. And second is a little bit more technical, and third one I will elaborate. So the key instrument to affect physicians and hospitals' behavior is incentives. The incentives national health insurance can control is money. What method do you pay to the doctors and hospitals? And how much do you pay? By 1980, when we would design national health insurance, we know the fee-for-service payment is a wrong method from worldwide experience. One, we prove through academic research is inflationary. You wait the patients get sick. The patient come in, then you get money from the patient or the insurance company. You do not prevent. Second, the more you come, the patients come, the more revenue you get, higher your income. This was proven by empirical evidence around the world. At that time, Taiwan's physicians were not organized because under Kuomintang, Nationalist Party, they did not allow different civic groups to be organized. So President Lee of the Taiwan at that time asked me to meet with 14 most prestigious senior physicians to negotiate how to change the payment method and also what rate they want. I failed. The government paid 4 private dinners with 14 senior ministers. They're called 医学大佬, okay? I could not persuade them. I turned back to President Lee. I told him I failed his direction. He told me, okay, I would take over myself to see what can be done. Then when I returned to Taiwan much later, he pulled me aside at a meeting. He said, Professor Xiao, I'm sorry, I failed. But he said, I will keep on trying. And today, you are still trying, 30 years later. That is a flaw we were not able to change in the Taiwan's health system. Then Taiwan has a patient side of tradition that came from Japan. Minister Shu mentioned Taiwan average number of visits per patient, per person is 16 times. What country has the same rate? Can you guess? What do you think the European countries the United States has? Let me give you the answer for the United States and European countries. It's less than 6 times. And their population are older. So it's not because of aging. They have less than 6 times per visit. But one country was special, Japan. Japan has 15 visits per person today. Taiwan's tradition from the patient side, as well as the physician's practice side, came from Japan. When we study how to reform and introduce national health insurance to Taiwan, we're trying to trace that history. Then we say, how could we change that? That change has to come from the benefit design as well as the payment system. We were not able to do it. So that remains with Taiwan. Consequently, Taiwan, later on I will summarize, you have too many patient visits, but they're very short. 5 minutes. Doctors, to satisfy the patients, just prescribe drugs to patients, say, you got something. Patients do not necessarily take the drugs. Patients actually throw away the drugs. Or there is a secondary market being created in Taiwan for these unused prescription drugs. To also deal with the patients on such short period of time, I order X-ray, CT scan, MRI. So patient says, I got something. So Taiwan has an over-prescription of drugs, tests, and including hospitalization. This is all mostly generated from 2 reasons. traditional practices inherited from Japan. Second, we were unable to change the payment system and change the incentives on the patients as well as the doctors. So then let me move on to say, besides the original, we were not able to change the incentives and practices that patients, we were proposing patient education, but that never got developed because I was only involved with the first phase of the planning. In the second phase, it was taken over by some other people, and they did not pay attention. How do we change patients' minds and practices? Patients can be educated. Then, let me bore you with a little bit technical. In the planning, Taiwan did not develop a social health insurance. Social health insurance is not a tax-funded program. It's a social compact between the people and the government. People say, I will pay certain premium or taxes, but you promise me for certain benefits. And that contract usually is over decades long. Consequently, in designing social health insurance, you need certain actuarial principles. Taiwan did not follow that. Why? Because later on, when I re-entered Taiwan, the premier told me, oh, I don't want to set the tax rates, the premium rates, over 25 years. That's what US had done right. And the Medicare, United States set a premium rate for 25 years. So you get a very early warning when you're not doing well. And you don't have every other year ask for tax or premium increases. The premier at that time told me, no, Xinzhenyuan, that's the executive branch, we would like to control that. Because politically, sometimes we want to do little favors here or there. Because Taiwan was going to become a democracy. So that's not in your plan. You are right now only making financial plan for a year or two. You make a short forecast. You do not set your financial analysis and premium and tax rates into 20 years, 25 years. That's why Taiwan's national health insurance faced periodic financial crisis. And then who gets hurt when you don't raise adequate money? Actually, it's the physicians and nurses. They have to work longer hours and lower pay, particularly the junior ones, young people. So when you look at Taiwan's national health insurance, it's a great success, but there are underlying undercurrents. That's why I dare to take this opportunity to bring it out. I apologize to my host. So then the third historical flaw was because we did not insulate Taiwan's national health insurance from political interference. President Li Denghui, when he saw me privately at that time once a month, he told me, when we create a national health insurance, we're going to create a big, delicious cake. Everyone wants a big piece. Every political group that have economic interest want to grab a bigger piece. You have to design one, insulate as much as you can from political interference. We tried. We first created the agency that managed national health insurance as a quasi-government agency. It's not subject to the legislative yuan to appropriate money, to interfere with the operations. But later, you changed it. That was only a modest effort, which we call insulation. And I won't elaborate the other methods to insulate from the political interference, because that's a rich piece of money, a big, delicious cake. Everyone wants a big piece. And that was a design flaw. So then let me move quickly with the time I have allowed. This is already presented by Minister Shu. Actually, I just here compare the condition change from 35 years ago when we designed Taiwan National Health Insurance. Aging of the population is one reason. Second, Taiwan's income disparity have definitely increased. And Taiwan's industrial organization has changed. Taiwan has become much more urbanized. Housing costs have increased. Last but not least, Taiwanese people have got so accustomed to a good healthcare system, they raise their expectations. They want everything technology allowed, but they say, I don't want to pay for it. That's a problem. I work in 40 countries. That's a problem faced every country I entered. Usually the Minister of Finance, the first question is, people want the best health care, but they don't want to pay. You as the economist, what's your answer to that? Well, there are some solutions, okay, but I won't bore you with it. I'm not sure the solutions is appropriate for Taiwan. So, besides the current condition has changed from 35 years ago, the future already is showing its light. And I already mentioned AI, robotic, and Minister Shu mentioned about telemedicine. There are a lot more. The discovery of new drugs, new techniques. And as you know, President Putin talked to Xi Jinping. They say, oh, now we can live 150 years. These things are on the horizon. a health system has to plan and think and change to sustain itself for all the people on an equitable basis. But that takes advanced planning. The change you're making, it may take a decade. So I will not, what are some of the symptoms the current system has the problems? One, in what the people in Taiwan knows, people say the system is wasteful, 浪费. They know that. People know it's a wasteful system. Too many visits, too many drugs taken and used, too many tests, over-hospitalization. Private insurance is rampantly increasing, but not regulated. It takes on the worst private insurance characteristics of the United States from 40, 50 years ago. Exploiting patients. I can testify to that. There are things have to be addressed. The periodic deficit is only a symptom. The cause is much deeper. Consequently, Taiwan has a shortage of doctors and nurses, particularly in certain procedures. Meanwhile, I've been here only less than 24 hours. I'm told the most flourishing specialty is cosmetic surgery. The young doctors who want to go to dermatology or cosmetic surgery, because that's where it's profit. So I will not enumerate all the problems I list here for you. Then let me conclude what I would recommend then. I would recommend the president or the premier name a bipartisan high-level commission to look toward the future. Minister Shu already mentioned what he intends to do, and they are wonderful measures. But they do not deal with some of the fundamental things, like you did not mention how you're going to change the payment system, or how you're going to change the manpower supply. So your solution is wonderful, needed, but it's more short-term. There's longer sustaining problems facing Taiwan. With that, I thank you for your attention and patience.
Thank you, Professor Xiao, for your very insightful presentation. Our next speaker is Professor Martin McKee. He is a professor of European Public Health at the London School of Hygiene and Tropical Medicine. He is one of the most important supporters of our Global Health and Welfare Forum in Taiwan and attends the forum every year. So now, let's welcome Professor McKee with warm applause.
Well, thank you very much, and it is great to be here. I realized last night that I need to do some counting because people were asking me how many times I have been to Taiwan, and I actually don't know the answer. I think it's between 25 and 30 times. But anyway, it's great to be back. So, ministers, ambassadors, friends, and we got the first slide up. So, get this to work. I'm obviously pointing it at the wrong place. Yeah, okay. So, this is a slide that I think you'll be familiar with. For decades, global health has been one of the most remarkable stories of international cooperation. Whether it's the eradication of smallpox or the dramatic reductions in child mortality we see here, or the global response to HIV/AIDS, the progress that we have seen has been driven by shared commitments, by scientific integrity, and by multilateral institutions. Now, at the heart of all of this has been the United States, not just as the largest financial contributor to global health initiatives, but also as a source of technical expertise, of innovation, and of diplomatic leadership. Why is this going? Okay. But the United States is now retreating from its leadership role in global health. And this withdrawal is part of a broader rejection of the rules-based international order that has governed global relations since the end of World War II. Institutions like the World Health Organization that were once central to coordinating global responses to pandemics and to health emergencies are facing significant funding cuts and political pressure. The Paris Climate Accord, which links environmental sustainability to health outcomes, has been undermined, and even the International Court of Justice, a symbol of global accountability, is being sidelined. Now, this erosion of multilateralism isn't just a diplomatic concern, it has direct consequences for health. The WHO's ability to coordinate pandemic preparedness and it depends on stable funding and on political legitimacy. And when major powers remove their support or question its authority, the entire global architecture begins to fracture. Now, this situation is compounded by geopolitical tensions. As everyone in this room knows, Taiwan has become a flashpoint in the broader contest between democratic and authoritarian models of governance. Its exclusion from WHO meetings, despite its strong public health record, highlights how political disputes can obstruct cooperation, even in areas where lives are at stake. Yet Taiwan also illustrates the potential for alternative engagement through regional networks, such as we see here, academic partnerships, and through civil society, even when formal diplomatic channels are blocked. So where is public health in this new world order? A few years ago, I had the opportunity to think about this in depth. I was asked by the regional director of the European region of WHO to contribute to the Pan-European Commission on Health and Sustainable Development, and in fact, I wrote the evidence review and drafted the scientific report. Now, in the background to the work that we did, we could see all too clearly that the health community in Europe was unprepared for the COVID-19 pandemic. This came as a shock because we were incredibly complacent. For decades, our scientists and our public health experts had been warning of the risk posed by new pathogens, especially those on the interface between human animals and the environment. But despite those warnings, most governments and global institutions had failed to prepare adequately. Now, if we look at the Global Health Security Index, which was published in 2019, just before the pandemic, this told us that the USA and the UK were the best prepared countries in the world. So why did they perform so badly? Why did we have to wait for a global crisis to expose the deep vulnerabilities in our health systems, our governance structures, and our societal resilience? And if we were unprepared then, would we be any better prepared when we faced the next threat? So we asked a few basic questions in the Commission. What went wrong during the pandemic response? How can we prevent similar crises in the future? And what structural changes are needed to build resilient, equitable, and sustainable health systems? Our approach was both broad and anticipatory. Rather than focusing purely on pandemic preparedness, we examined the full spectrum of health determinants, including the commercial, the political, the environmental, and the social factors. We adopted a One Health lens, recognizing the interconnectedness of human, animal, and planetary health. And we emphasized the need for systems thinking so we could see the big picture. Our work was grounded in the understanding that health threats do not arise in isolation. Risks emerge from complex interactions between economic systems, environmental degradation, political instability, social inequality, and much else. And if we were to anticipate future crises, we would need to take a whole-of-society approach supported by robust data systems, cross-sectoral collaboration, and inclusive governance. All of these we discuss in our report. And this meant moving beyond a reactive style of crisis management towards proactive resilience building. It meant improving and strengthening our surveillance systems, investing in early warning systems, and embedding health considerations in economic forecasting and risk management. Crucially, it also involved addressing the commercial and the political determinants of health. So how does this help us as we think about the challenges we face today? Well, I believe that we now face another global threat to health. This time, it isn't a virus, at least not in the scientific sense, yet it has much in common with a virus. It spreads rapidly from person to person. It crosses borders with ease. It damages those it comes in contact with. And we don't have a vaccine or even an effective means of treatment for its consequences. And this threat is radical populism. And I would argue it is just as much a threat as a virus with pandemic potential. Now, this is happening at a time when we are witnessing a profound internal crisis within public health itself. In the United States, populist leaders have actively undermined scientific institutions. Excuse me. Advisory bodies have been dismantled, experts have been dismissed, and research agendas have been redirected to align with ideological narratives. Vaccine skepticism that was once a fringe concern has now been mainstreamed. Now we can see how this movement is crossing borders. Arguably, it didn't arise in the United States first. Some commentators have argued that Donald Trump is simply copying the tactics adopted by Viktor Orban in Hungary. And now we're seeing growing movements in many countries. Even when populists are not in power, mainstream parties are encroaching on their ideological territory, challenging inclusive health policies, defunding diversity and equity initiatives, and framing migrants as threats rather than people with individual and legitimate health needs. Public health institutions that were once seen as neutral and evidence-driven are increasingly vulnerable to political interference. And we should not forget the historical aspect. Just as COVID forced us to relearn the lessons of the 1918 flu pandemic, historians call on us to look to the history of political threats. In his book on tyranny, Timothy Snyder offers a stark and timely warning about the fragility of democratic institutions and the ease with which they can be dismantled. Drawing lessons from the 20th century, Snyder outlines 20 practical principles for resisting authoritarianism, many of which resonate powerfully today. He cautions against the normalization of lies, the erosion of truth, and the manipulation of language, all tactics that are employed by populist regimes today. For the public health community, Snyder's insights underscore the importance of defending evidence, protecting truth tellers, and resisting the politicization of science, all essential for preserving both democratic values and the integrity of health systems. Now, the consequences of the spread of populism are stark. Trust in science is eroding, guidelines are being questioned or ignored, Vaccine uptake is declining, especially among marginalized populations. Preventive care is being delayed. And misinformation, we know, spreads faster than corrections, amplified by social media algorithms that reward outrage over nuance. This is not just a crisis of communication, it's a crisis of governance. And if this continues, the gains of the last 50 years, the gains I showed you in an earlier slide, could easily be reversed, and in some places already are being. And the most vulnerable will suffer first and most. So what must we do about this? Well, in a recent paper, we set out a roadmap for how public health can adapt and resist. And we proposed 9 interlinked strategies that together form a new vision for public health action. This is a strategy that we hope is politically literate, ethically grounded, and resilient in the face of populist disruption. The first thing that we need to do is to build a capacity for crisis response. Public health must be proactive, not reactive. So we talk about the creation of diplomacy laboratories, interdisciplinary spaces for simulation, negotiation, and strategic foresight that can allow public health professionals, diplomats, and civil society to rehearse and respond to the responses to emerging threats. The second is to empower non-state and subnational actors. When national governments are compromised by populist agendas, then it is time for cities, regions, universities, and non-governmental organizations to come together because they often retain the credibility and the capacity to act. But they must be supported to form cross-border coalitions, to share resources, and to advocate for evidence-based policies. Public health must engage with all of these groups and create platforms for coordinated action. Now, the third is to institutionalize learning. Populism thrives in populations that feel unheard. My colleague Jacob Boer produced this paper, this graph, which shows how the shift from voting Democrat in 2015 to voting for Donald Trump is correlated closely with falling life expectancy in American counties. We showed the same with votes to leave the European Union in England during the Brexit referendum. And in earlier work, we've looked at the association between increasing mortality and austerity and votes for the Nazi Party in the Weimar Republic. And this means that public health need to develop media-trained spokespeople who can communicate clearly, credibly, and compassionately. We need to use digital tools to monitor public sentiment and to counter misinformation before it spreads. Our strategic messaging must anticipate populist narratives and offer compelling alternatives. Listening is not a luxury, it is a necessity for rebuilding trust. And trust is something that is lacking today. In 2024, WHO Euro held a ministerial meeting in Tallinn, Estonia, on this issue. And this is the book that we wrote for that meeting. And in our book, we discuss how trust is conceived by different disciplines, how it can be measured, and crucially, how it can be restored. And you can download it freely with the QR code there. The fourth of my 9 is the need to protect health workers and defenders of truth. Health workers, journalists, whistleblowers are often the first targets of populist regimes. And as we have seen tragically, both journalists and health workers no longer have the protection in conflict zones that they should have under the laws of armed conflict. Indeed, they are being directly targeted because they are witnesses to war crimes. Public health must demand protection for these individuals through legal defense funds, diplomatic support networks, and international solidarity campaigns. Their safety is essential to maintaining transparency and accountability, especially in contexts where corruption and censorship threaten health systems. The fifth is to build alternative accountability systems. When official channels are compromised, alternative systems must emerge to uphold transparency with independent data platforms, verification mechanisms, and civil society watchdogs, all providing credible information and monitoring abuses. If you're not familiar with it, the open source intelligence organization Bellingcat is an excellent example. Public health must partner with investigative media and with advocacy organizations to ensure that trust persists even when institutions fail. The sixth is to reframe health as a priority. Health is not just a technical concern, it's a strategic asset. Public health must position itself as central to foreign policy, to national security and economic resilience. And actually only yesterday we published from the European Public Health Association a paper about the role of public health in hybrid warfare, the hybrid warfare that we in Europe are now facing from Russia. This shift from health in all policies to health for all policies means advocating for health impact assessments across all major policy domains. And the seventh is to protect institutions. Populist regimes often politicize funding, threatening the independence of public health institutions. Multilateral organizations, philanthropic foundations, and regional networks need to mobilize to provide flexible, reliable support, because we need to reduce dependence on politicized national budgets and reduce the scope for political appointments and secure the right to publish data and reports that safeguarding autonomy and ensuring continuity. And this is something that we're very concerned about in the United Kingdom. I and my colleagues have just published this report looking at where our independent agencies are vulnerable, and you will know that we have a very populist party in the wing, waiting in the wings, and we've been looking at how our bodies can be strengthened and how they can be supported. Reassuringly, in our polling data, we find the public are on our side. The eighth, and I'm getting close to the end, is to develop a new curriculum for public health, relevant for people like myself in schools of public health. The next generation of public health leaders must be equipped not only with technical expertise, but with advocacy skills and diplomatic acumen. A new curriculum is needed that integrates ethics, negotiation, political literacy, and systems thinking. And ninth, we must defend and revitalize multilateralism. Multilateral institutions are under attack, yet they remain essential to global health diplomacy. Public health must defend these institutions while pushing for reform to make them more inclusive, transparent, and resilient. Public health voices must be present in treaty negotiations, in standard-setting processes, and in all international forums. Reinventing multilateralism means building alliances across sectors and regions, ensuring that public health remains a unifying force in a divided world. The public health community cannot afford to be passive in the face of populism. The stakes are simply too high. Silence enables disinformation. Inaction allows the erosion of trust. And this requires courage. And here I want to pay tribute to our next speaker, George Benjamin, whose courage in standing up to the Trump administration has been an inspiration to us all. At a time when not just universities, but law firms and corporations have capitulated, the American Public Health Association has stood firm. So we in public health must be bold, inclusive, and become a strategic force. By empowering diverse actors, by defending truth tellers, and by reforming institutions, we can safeguard public health as a foundation for peace and for global progress. In a fractured world, public health must be a beacon of hope, resilience, and must be principled, and it must be ready to lead. Thank you very much indeed.
Now, let us thank Professor McGee for his very inspiring speech. Let us give a big applause for you. Our final speaker this morning is Dr. Georges Benjamin, and just been introduced by Professor McGee. He is an internationally renowned health policy leader, practitioner, and administrator. He served as the executive director of the American Public Health Association and the nation's largest and oldest organization of public health professionals. He will present on how policy and system redesign can ensure that everyone can enjoy optimal and sustainable health in the post-pandemic era. Please join me in giving a warm applause to Dr. Benjamin.
Well, good morning, everybody. Minister Shu and distinguished guests, thank you very much for allowing me to spend some time with you. And Martin, you'll get your check for that introduction a little later than today. Let me just say that I've only been here 4 times, so I've got a few more times to go before I can catch up with you. Let me say, I don't really have any financial conflicts. I always mention this in any of my talks, but I absolutely have a bias. And it's important everyone understand that bias because it's about health. I believe that the secret of life is to live as long as you can, as well as you can, and have a short but glorious ending. And the challenge we have, I think, in the business that we're in is trying to build systems to achieve that, equitable systems so that everyone can achieve optimal health. So with that bias, you know, I like the World Health Organization's definition of health. I think it's inclusive. It is holistic in the way it thinks about it, and I think most of us at some point have used this definition. I trained in internal medicine, but spent most of my time as a clinician practicing emergency medicine. And one of the more painful revelations, I certainly believe that healthcare is a fundamental human right, but one of the more painful revelations is that 80% of what makes you healthy, of course, occurs outside the doctor's office. And as a guy who enjoyed taking care of very sick patients, loved the bells and whistles in emergency departments and intensive care units, it's very painful to recognize that the things I'm going to talk about today are the things that really wrap around health insurance, which is in essence, you get into the system card to help you improve health. The other thing I think that's important is to talk about the 4 things that I think are important in order to achieve equity in our systems. Number 1, access to care. And of course, as you know, access to care is more than an insurance card. There's a whole range of other factors that are involved that ensure that people have access to care. Secondly is the issues of quality of care received within the healthcare setting. That certainly determines how well you're going to do health from a health perspective. Individual health-seeking behaviors. We heard earlier about the fact that in Taiwan here, you're highly overutilizers. In the United States, we are, some might argue in some situations, low utilizers, but very expensive low utilizers. But I think the big one is, of course, the issues around the social determinants of health. Those are the things that help you become healthy or can serve as a major barrier to you being healthy. And so I'm going to talk a bit about the social determinants, recognizing that when you need the healthcare system, you need the healthcare system. There's no question that health is a fundamental human right, and we ought to be working to achieve that as quickly as well as we can. So as we think about that, just recognize that most health systems, most finance systems pay for care. I think as Taiwan begins to look at how you might want to change your payment system, just like in the United States, we're beginning to think about how to pay for value, how to pay for prevention, how to wrap in these social determinants. The truth of the matter is we're trying to figure out how we pay for it in a way that does not become corrosive to folks that actually need that care when they need that care. We also know that the quality of care you receive is directly related to where you live. Your zip code is a strong, strong determinant of health outcomes because it determines where your job is, where you live, toxic exposures, public transportation, depending on where you live, social cohesion, a major determinant of our communities. Whether those communities are safe, access to nutritious foods, all these things, of course, are determined by where you live. And just about every nation has this challenge. Taiwan certainly has differences in terms of health outcomes based on where you live. You know, in the United States, we pay a lot of attention when we talk about race. But this is the state of West Virginia in the United States. It is 97% white. And depending on where you live, still matters. I'm going to bring your attention to these two counties, Mason County and Putnam County. This was a study done by one of our insurance companies. And there is a 2-year life expectancy difference depending on where you live in this county. Not a difference in demographics racially, although we know race is a sociological construct. It's a surrogate for a lot of other things. But there are differences in the social structures, the benefits of living in one county over the other, which ultimately results in a difference in where you live. This is a street in St. Louis, Missouri, called Delmar Boulevard. And Delmar Boulevard has enormous differences. As you drive down that street, you look right, you see a great deal of impoverishment. If you look left, you see a great deal of influence. Turns out if you look right, that's a minority community. If you look left, that turns out to be primarily a white community. And at least in the United States, every community, every city has a street like this. It's called Railroad Boulevard or Martin Luther King Boulevard. We often name them after Martin Luther King. They're called Main Street. But everybody knows that there is a street in your community. If you look one way, you see rich folks. You look the other way, you see more poor folks. And they segregate based on this. And in the United States, we have constructed this, many over the years, through government policy called redlining, in order to make sure that we kept people in their place. That in the United States, of course, is called structural racism. But we also know there are other things that happen. Infrastructure is a social determinant. There's no question. If it hurts people or kills people, I would argue that it's ours. And so we need to begin paying attention to the failing infrastructure in many of our countries that we're not invested in. Water. Our central cities in the United States, for example, are getting older. Most of the piping that was built are built with lead-lined pipes. And of course, those pipes are leaching. Now this is Flint, Michigan, the challenge we had in one of our big cities, Flint, Michigan. And for a bunch of political reasons, they changed the way they managed their water system, which resulted in more leaching in the water, which resulted with more lead in the water, which created greater exposure to these kids with lead water. They haven't quite fixed it all yet. They've been working on it, but every central city in the United States, and I would argue Europe being structurally much older, has many of the same problems that we're having with these central systems. And we're going to have to pay a lot more attention to investing in these systems. That means that the health in all policies concept is a very important one as we go forward. Bad air, making sure the air is safe to breathe. There was a time in the United States, and I think certainly many of the cities, certainly in Europe, I understand also in China, where you go outside and you really couldn't walk. You know, you walk around and you run, and you had to pick the stuff out of your teeth before we began cleaning the air. And so there's been a lot of effort to improve the quality of the air that we have, just because of the toxins that we historically have put in due to urbanization in our big cities. Now, climate change plays a big role. I know there are still an enormous number of climate change deniers out there, despite the dramatic changes that we're having in parts of the world where we have too much heat in places, too much cold in other places, too much snow, too much rain, severe weather. Climate change is real, it's impacting our health today, and we need to pay a lot more attention to this as part of our health system. On where we dump our trash, major issue all over the world. We really don't manage trash well on our planet. When I was a health officer in Washington, D.C. for a couple of years, and those of you who've been in Washington, D.C. know there's a 14th Street bridge moves from Virginia into beautiful downtown. And if you, going north, if you go left, you go into the more affluent part of the city. If you go right, you go into the more impoverished part of the city. Well, at night, illegal trash haulers would come across that bridge, and they would go into the poorer part of town where there were a lot of vacant lots, and they would dump their trash. And so one of the important public health interventions we have was to put police officers on the bridge to either turn them around, arrest them, or stop them from doing their trash. I always find it quite interesting that politically they always went into the poor part of town when there were also vacant lots in the wealthy part of town. But that's what it was. We see this a lot where we're not paying enough attention to trash. Food insecurity, we talk a lot about food deserts. Food deserts, there are certainly places where there's no safe, affordable foods, but most of them, at least in the United States, look like this. They're small, family-run stores where they sell a lot of high-fat, high-salt, low-nutritious foods. They make their margin off of selling alcohol and tobacco. And they are community assets, but after you've been working 2 shifts and you're coming home at night, there's no grocery store in those communities. And in fact, in many of our communities, there's been a failure to be able to actually put good grocery stores in those communities. And even places where we've had commercial places like 7-Elevens and some of the other convenience stores quite commonly do not have the facilities to sell high, nutritious foods in those communities for people on the hours in which they work. We know that the criminalization of substance misuse is becoming a major problem in many of our communities, and it's something we need to think about whether or not we're really accomplishing the goals. I mean, the fact is you can put people in jail, but unless you begin to give them the appropriate care and treatment that they deserve, they're simply going to just revolve in and out of the system. It's going to be more costly. And homelessness continues to flourish all around the planet. Poor health is a major cause of homelessness. It has a higher morbidity, a higher mortality. As you know, quite often, most of the homeless are kids, people who've lost their homes. And in the United States, at least, healthcare costs is a major cause of bankruptcy. Education is an important determinant of health. And as many of you may know, that the better educated a woman is, the more likely her child is to survive their first year of life. And every place I can think of, every part of the world that's ever looked at this has been true. Education is a major determinant. I don't know that really everyone understands all the reasons for that, whether it's a surrogate for other things, it's a surrogate for education, it's a surrogate for income, better health literacy, et cetera. It's certainly true and something that we need to pay a lot more attention to. And then violence. Now, coming from the United States, firearm-related violence is a major determinant of health in our country. It is really a political determinant because we actually know how to reduce gun violence. It is, and people say guns don't kill people, but it is true that people kill people with guns, and that it's infectious. It behaves very much like an infectious disease, and so we actually have to get around this, and hopefully one of these days, even in the United States, we'll get the political will to do something about it. Economic inequality clearly is a big issue for determinants of health. I would love to be able to live in this house. You know, I'm really working on trying to get there. But tragically, far too many people live in places like this. The injury, the exposure to toxins, the degradation of many of our central cities around the world is a major problem. We have to pay much more attention to this. In addition to just simply making sure people get health insurance coverage and get the care that they need. You know, we often talk about the differences between equality, where we work to try to make sure everybody has the same resources, equal resources, but that doesn't really solve the problem. Equity, where we give people what they need as kind of a structural component of trying to make sure they can get to optimal health. But at the end of the day, we really ought to be trying to get to justice. Justice meaning that you can see there's a fence there in those other two models. The idea is to move the fence in such a way that regardless of what your height is, you can actually see the game. And that's what we need to be trying to achieve in our health systems. So that I'll stop. I'll thank you. And I know I'm right before lunch, so.
Yes, thank you very much to Dr. Benjamin for the perfect time control. Thank you so much. Yes, in between lunch, we just wonder if you have any questions for our previous speakers in this keynote session. We still have a few minutes time. Do you have any questions? 那各位贵宾，我们还有几分钟的时间哦，想要请教各位贵宾有没有要提问的？针对好，那我们前面有麦克风，都欢迎您到前面来使用一下。麦克风好像没有开哦，工作人员帮我们。
I have a question for Professor
Yes, please.
McKee. You just mentioned that our current or newer generation public health workers need to acquire skills like diplomacy, communication skills, and these are not the traditional core curriculum in this field. Can you elaborate?
Well, I think we all need to acquire new skills. So Bill was mentioning artificial intelligence. We have a book entitled Demystifying Artificial Intelligence for Health Policymakers coming out in about a month's time. And I've been spending much of this year at my advanced age trying to understand AI. So it's not just for young people, we all do. But definitely we do teach communication. We do teach cognitive biases. We do teach disinformation and how to combat it. But I think we all need to do more of that because so many of the things that we took for granted are now being challenged by blatant lies, falsehoods. And also we need to try to, it's not just teaching skills, it's instilling courage. I already mentioned George's stance. I'd also like to call out somebody else who's demonstrated tremendous courage today, and that's at Belém, and that's the climate minister from Tuvalu, who has been the only minister to speak out against the American stance on climate change. So I'd like to, a shout out to that too, because we should celebrate courage when we see it. So I think we need to convey values, but we also need a new range of skills. But as I say, if I can begin to understand AI at my age, anybody can.
Thank you very much to Professor McKee, and to thank you very much for your question. And to thank all 4 speakers for their wonderful presentations. Our moderator, Professor Chen, would like to present certificates of appreciation to all speakers in this session. So for that, we'd like to welcome back our moderator, Professor Chen, and all 4 speakers back to the stage. We'd like to welcome Minister Shu back to the stage, Professor William Qinglun Xiao back to the stage, Professor Martin McKee, and also Dr. Georges Benjamin. 那接下来呢，我们就有请这个场次的4位主讲人，我们回到舞台上哦。要有请我们的主持人代表主办单位致赠感谢状。Firstly, to our first speaker in this session, Minister Chong Liang-shi。我们首先呢，我们就依照演讲的顺序来颁发哦。有请我们的主持人陈建仁院士先颁发给徐崇良部长。Let's have a photo. Thank you. And then to Professor William Qinglun Xiao. 接下来呢，我们颁发给萧庆伦教授。Let's have a photo together. And then to Professor Martin McKee. 接下来呢，我们颁发给我们的好朋友 Professor Martin McKee. All right, let's have a photo together. And Dr. Georges Benjamin. Thank you so much. And one last photo with all the speakers and moderator. Yes, Professor Chen in the middle. 好，那我们请这个场次的主持人以及4位主讲人，我们在台上一起合影。Okay, show us the certificates of appreciation. 我们把这个感谢状把它翻到正面，我们一起来合照。Okay, everybody, let's give your moderator and speakers of the keynote speech session another big round of applause. Thank you so much for your valuable inputs. Thank you. 再次谢谢我们专题演讲场次的主持人以及4位主讲人。Ladies and gentlemen, that's it for the morning, and it's time for lunch. Please follow our staff to the 3rd floor. We have lunch ready for you, and be back before 1:30 for plenary session 1. And we have an exhibition outside for you to have a look back at the 30 years history of Taiwan's national health insurance. Do pay the exhibition a visit when you have time. Thank you, and we'll see you in the afternoon. 各位贵宾，那接下来呢是中午用餐时间哦，都请各位贵宾呢移驾到3楼，请各位贵宾呢移驾到3楼享用午餐。那么场外呢也有台湾健保30年的特展，大家等一下有时间呢都可以来参观哦。那么下午场次 plenary 大会场次第1场1点半会准时开始，我们下午见，拜拜。 All right, ladies and gentlemen, the afternoon session will begin in a few minutes. You may start to take your seats. Thank you very much. 提醒各位贵宾，我们下午场呢，再过几分钟之后就会正式开始了，请您准备回座，谢谢。Okay, everybody, please take your seats now. We're ready to begin the afternoon session. Thank you very much. 有请各位贵宾现在紧速就座，我们下午场呢马上要正式开始了，谢谢。 All right, welcome back, ladies and gentlemen. We hope you all have enjoyed your lunch. We're now in plenary session 1, and we're going to explore the interplay between public health and national health insurance. 欢迎各位贵宾呢继续回到我们大会的会场哦。那接下来呢是我们大会主场的第一个场次，我们要聚焦的就是公卫以及健保之间的关联性哦。那首先呢，我们要有请主场场次1的主持人上台，我们开场。Ladies and gentlemen, now to open this session, please join me in welcoming Dr. Jingyi Lin, Deputy Minister, Ministry of Health and Welfare, ROC Taiwan, to the stage. 让我们掌声欢迎卫生福利部林静怡次长上台，我们开场。好，我们次长慢慢走就可以了，谢谢。
Thank you. Once again, it's such a great time to see all our friends here, and we will have a very, very excellent panel this afternoon. The national health insurance systems, I think we want to talk about the national health insurance and our public health corporations, how to guarantee our health services and public health. So the national health insurance systems serve as a cornerstone for state safety garden to public health, and it's essential to ensuring Taiwan we keep our sustainability of medical services. We also got a lot of experience and cooperations during the COVID-19 pandemic when it enabled to effective resources mobilizations and strengthen national resilience. This experience highlights the vital importance of strengthening international cooperations and learning from global best practice. Today's sections offers a valuable opportunity to explore ways to build healthcare systems and that are both resilient and sustainable. We will deliver 2 key topics, including European health corporations and health insurance financing models, the effectiveness of integrated health system, and the Taiwan's successful approach to liver disease prevention. We warmly invited our distinguished experts to share their insight as we work together to develop a more comprehensive blueprint for universal health and health well-being. I'm pleased to introduce our 4 speakers in these sections. First speaker is Dr. Andreas J. Reis. Where is that? Welcome. He is former Deputy Minister of Health of Poland. And sorry, you could stay. I will introduce all the members. Sorry. sorry. He is a former Deputy Minister of Health of Poland, and he's a long-serving senior official of European Commission. He lead major EU health initiatives. During his tenure, he has overseen key projects in cross-border healthcare, tobacco control, pharmaceutic and medical device regulations, health technology assessment, digital health, and global health. Our second speaker is Dr. Chen Liangyu. She is Director of Journal of National Health Insurance Administration, Ministry of Health and Welfare. She is a highly comprehensive accomplished expert in public and mental health, with a distinguished career span with both clinic practice and administrative leadership. She previously served as Director General of Department of Mental Health. She initiated our major public health initiative for mental health and the adolescent mental health screenings and counselings. She holding a PhD from Johns Hopkins Brown School of Public Health. And Dr. Chen, she expertise is exceptionally well aligned with today's topic. Next is my great pleasure and honor to introduce the third our speakers. The Professor Chen Jianren. He is academic student at Academic Synthetica and served as our 13th Vice President of Taiwan from 2016 to 2020. Professor Chen, he also held position as Minister of Health, Minister of National Science Council, and Premier. Professor Chen, he is a distinguished epidemiologist and a public health leader. He is renowned for his pivotal leadership in Taiwan's successful containment of SARS epidemics in 2003 and the COVID-19 epidemics in 2020. He's a pioneering researcher in this molecular and genomic epidemiology of virus cases, cancer, and health hazards. We are honorable to have him share his insight on the strategies and achievement in the elimination of end stage of liver disease in Taiwan. Actually, we will have a report in next year about our elimination of hepatitis C. Our four speakers in this section is Mr. Joseph Kutis, a health economist with 40 years of experience. He worked at the World Bank before joining WHO in 1994. During his tenure at WHO, he held various key roles, including leading the health financing team globally until his retirement in 2023. He has published extensively on health system, financing, and universal health coverage. And he is known for his influential health financing framework. He currently works as an independent consultant and serves as senior fellow at Resort for Development. I'm sorry because I'm a little disconvenient, so I need to introduce all four speakers at the same time. I think we would like to thank all our distinguished speakers for these very, very enlightened panels. So now I think we will welcome all our speakers in this section. Thank you.
Thank you very much to our moderator, Dr. Jingyi Lin. 非常谢谢主持人林静怡次长。And now we'd like to welcome our first speaker, Dr. Andre Jan Ries, board member of Medical Research Agency Poland and former principal science advisor of DG Sante, European Commission, to talk about how to think globally, act locally, renewing public health through learning, sharing, and cooperation. 那接下来呢，我们就掌声有请我们第一位的主讲人，波兰医学研究机构的董事，同时也是欧盟执委会卫生及食品安全总署的前首席科学顾问。Ladies and gentlemen, I give you Dr. Andre Jan Ries. 掌声欢迎。
Thank you very much, Madam Minister, distinguished guests. It's a pleasure to speak here today. My topic of my presentation is about something we are basically exercising today. We are sharing our experience, our interests, our learnings, and I think after speech of Professor William Shaw, whom I have chance also, if I may say, invite to Poland and enjoy also his advice as you enjoy his advice 35 years ago. He did the same job to our government and to our project, this time Harvard University project. So we continue sharing experience, Dr. Chen, Professor Chen, during lunch. So it seems that we are in the right place to reflect a little bit about this, the way how we can improve this. Telling us that the world is in big trouble, if I may say, at least in turbulent waters. You know, I share the same feelings, but who we are if we will not find a solution for this turbulent waters. So let's continue this sharing, and I will start with a small anecdote also involving Professor Shu's story in this context. The time, you know, he was helping our government, and I was also this time in academia running the School of Public Health at Krakow University. We visited Ministry of Health, and it was evening as usual. You cannot meet ministers in the normal working hours. We got appointment after, I think, 6 p.m. in Warsaw. So I was with my friends from Harvard. We were stepping on the stairs to the minister's main office, and it was a cleaning lady preparing, I think, for the next day. And she asked me gently, who are these visitors? Because she understood I am Polish, so she can speak freely Polish to me. And I said, they are Americans. And she said, the American doctors. And I said, no, they are mainly economists. And she said, Jesus Christ. So, you know, the words of sharing, advising may also be in trouble when you start to see the reality of the day. You know, when you try to understand what is the good practice, sharing public health, you know, it's about exchange of approaches, intervention, about how we can learn between the professionals, organizations, institutions, and in the end, you know, how to avoid mistakes, how to accelerate our work, how to also improve simply what we are doing, you know, and I think many of us went through this exercise personally or as an organization. Myself, in all my roles as academic, as a local in the health department, and later as a deputy minister, also in the European Commission, I also spoke to my team. If you don't know how to do things, just open the door and see people, learn from others. So can we do this better? You know, so we wanted to understand this better. So you can do this also from our, you know, leaders from the past. So I brought, you know, a few examples, you know, that all of them, they both from Mencius, from this part of the world, from Seneca, who was the philosopher from Roma time in Europe, and Dr. Albert Schweitzer, you know, whom we know from as a humanist and doctor working in Africa. All of them basically say the same. Example is the best teacher, you know, in short, but you can read, you know, all those phrases, and I put them also in your language. Hopefully this is correct. So let's go to the next. So we have, you know, we as European Commission also try to follow the same exercise. We work closely with OECD, trying to find the right methodology. It ended up also with the so-called best practice portal, which you can go and see a number of practices we propose, we evaluated, and we believed using the methodology proposed by experts. They are good, interesting one to follow. And also I will follow later with some kind of examples how this could be improved. WHO Europe is also having such access portal you can see, and OECD also is in not only in health but in also other fields is pushing this way of sharing good practices in other sectors as well. In Europe, in European Union, we have in our DNA, in our treaty, EU treaty, we are asked to share. Sharing good practices is a way community is working and supposed to work together. And I can tell you, all my 19 years experience, European Union is really giving me, I think, right to say it's possible, it's workable, and I think we should use this as a way to develop new ideas, but also evaluate what we are doing. So why is important? First, because the efficiency, we can save resources, we need to reinvent the wheel. This is the simple statement. The quality, of course, is important. So of course, we can get better ways of doing things and do better effective intervention. Equity is other important issue. I think also in Dr. Benjamin's speech, we heard a lot about this. So we need to really think about those unserved population, how to reach them. And I think many those interventions, of course, are taking this into account. And innovations, as part of new ideas, what we can do and how we can do. Sorry, I moved too fast to the, it's not the plan, sorry. When you go to the core of this sharing, the one is about the evidence base, the data, and we need really to find the way to explain through data. And I think the COVID-19 was, I think, the most painful lessons. I think we learned that the data have been not too good, not the right time, and often not very wisely assessed and so on. Well documented is important that the process is well kind of defined and documented. But I think it's interesting to also focus on this ethical and cultural appropriateness, because this is what sometimes, in sharing is difficult. It's not easy to move one good model to other because of this issue. And of course, scalable and or adaptable issues are important, finally evaluated. This is the picture I took during last weeks. They are all oaks, but each of the oaks is a different story. The one, for example, to the left is from my university. It was planted to memorize, our professors who have been taken to the Nazi camps, beginning of the war. And, that we go there every year to kind of memorize them. The other one is, pick up one of those. This is from Berlin when it's planted, most probably 700 years. It was there when it was DDR and the communist building of the Council of DDR party there. Now is rebuilt the old beautiful castle from the old times of Germany. But of course, you have also those in Gastein, our favorite place to meet in Europe and debate and share. And I know Taiwan delegation often used to be there, and I hope you will continue come to this place. And also you have your own oaks here. But when you really see about them, everyone has different roots, everyone has different culture, the soil. So we should think about the sharing. Also about the way, that we plant our ideas in different places. Our ideas can grow, but of course there are conditions for this growth. But also each one practice is one story, has its own development. So how we can do this in practice? We can create a case studies template. We can use repositories for sharing. This is what you have seen in the European Commission website. You can develop learning networks, monthly webinars, and so on. So we can support developing from training, mentoring. So there are many tools, how to do it. In this guidebook, which was published 2 years ago by OECD colleagues, you can find the kind of 3 steps how to go with looking for those practices, selected public health and intervention, but of course you should think about evaluate it and choose them. implement them, basically looking for the stakeholder engagement, the resources of you have to employ, and adaptation already mentioned. And then finally, the third is easy and at the same very difficult step, how to evaluate them. So this is the other issues about the transferability of those practices. You know, again, here are examples what you have to carefully assess what works in the population context, in the sector-specific context, for example, what is the government, what is the regulatory environment. Sometimes you cannot move things because the regulatory environment is very simply not allowing to do things. Often also we are confronted with the workforce capacity. People are not trained, people are not prepared to accept these new concepts. So you have to think about training. Sometimes you may face the issues around the political context, like the will, but also it doesn't work with the priorities of the government. And then finally, also we can be confronted with simply with the economic context. This way of doing things is too expensive. You cannot afford as a government or local government or the society. We don't have the right funding mechanism. You know, for example, in my country, Poland, we established a few years ago the legal system, which allowed piloting, good examples, good ideas. But the very difficult problem is, of course, as already mentioned, evaluation, but also the time needed. You know, sometimes in the project or in this kind of pilot, you plan to do these things in 2-3 years, but in the end, you know, it's difficult to conclude them in the reasonable time, and then there's a big question, you know, it's already not working or simply it was wrongly planned. And finally, the guide also provides the kind of simple indicators how to use it. The planning and monitoring implementation is other big issues because, you know, here we need to think how to do it, you know, how we define the roles, how we define the set of measures for this, how we discuss about the adaptation, for example, in what kind of intervention in for example, in local context, in the city or in the small community, in the distance, you know, like in the village or unserved areas, and finally how we do ongoing implementation, and then we go to the rigorous evaluation. Here are many examples how you design this evaluation, how you select the appropriate outcome indicators. This is always very painful, how to define the right one. Outcome indicators, you know, you can discuss also through the KPIs, you know, system, which is also not easy. But collecting data is other problem because then you start to put people to the, you know, different places. Okay, bring us data, show us the data, do more surveys. Often we feel the kind of big opposition. You know, why I have to do it? You know, what will be my kind of gain in this exercise? So the checklist, you can see again the repetition of this issue already we discussed: effective, efficient, transferable, equitable, participatory, multi-sectoral, especially in the public health. I think Martin mentioned his speech about the importance of this issue, and finally how we can learn. There are some examples, you know, in this guidebook you can see the tobacco control, you know, the plain packaging is a great story. I have seen, you know, how it was moving from Australia towards Europe. We employed this relatively effectively across many jurisdictions, vaccination, and then was other in COVID vaccine. This is other interesting example we learn from each other. The healthy city programs, you know, this is also was very, very interesting issue. And I'm going quickly through the 3 cases. I would like to show you how this may work. This is something which is important for one of the priorities for European Union, antimicrobial resistance. We are having programs in this field. This example of the kind of government framework, multi-year framework, when we try to do it. In Europe, you know, this time of political documents are going through the process to the European Commission, Council of Ministers, but then also we have important involvement of European Parliament. And this is the document which was established 2023 with number of let's say, political targets, but also ways of doing things, you know, if I may say so. So these 9 points, they are our plan for in current period of work. But of course, when you go back to the history, why we did this, you know, the European Union, we are in the situation that we have number of deaths every year from antimicrobial resistance. We have a number of over 800,000 cases a year of this phenomena. We have number of losses when you count this in Dali. So basically, there were reasons to do it. There were economic reasons. There was also, of course, epidemiological reasons, and of course, there also was interest of the community. To help with this, we have 2 agencies, you know, assisting us this work. One is ECDC, which is the European Centre for Disease Control, which is having this public health agenda for European Union. And then we have also our European Medicine Agency. It's an important agency because of the databases and the way we can monitor the consumption of antibiotics, both in pharma, in human sector, but in animal sector. For those of you who are not familiar with the veterinary sector and veterinary medicines, our regulatory regulation in veterinary medicines is having, I think, first time in the history of Union, we have the public health chapter in the veterinary medicine regulation, which is really giving prescription how to use antibiotics, or not rather to use antibiotics in animals. So One Health approach, already mentioned again by Professor Matti Mäki, is there as well. And then in the end, you know, we have the targets and the way we would like to reduce or attack different issues. So this is government framework, but now we jump to the local government, which is the other journey. Local government, Krakow, I choose this because I think it's not only my city, but it's a very interesting story, maybe not well known internationally. We have very big smog problem in the Krakow city. And of course, you know, this is not the only city in the world having this trouble, but the whole story started, you see the number of smog days, 2012, 140 smog days in Krakow city. And in 2023, we have 20 smog days. And this was really because of number of interesting developments. First, I think it was important that local government decided to push the change, but also citizens of Krakow had basically been very unhappy with the quality of air, which also pushed the investment from the government, but it's also local government to change the coal and wood stone. It was totally eliminated. You can use wood in the fireplaces in Krakow, with some, you know, houses, rich houses been built, but they have very nice chimney. No wood is allowed to use. So, but what's happened? People went on streets they wanted to do. Citizens, they did this. They pushed this. There are continuing to be challenges. Now is the big issues around access for cars to the city and so on. But now other challenges, you can do job in your jurisdiction, but you live in the area. So the small cities or villages around the city of Krakow, they are not yet prepared. What's happened also with the story, this also created innovation, you know, and this innovation was triggered by young people, this startup community to create new ideas. By chance, also my son Maciek was involved in this. You can see his work, which was Sparks of Innovation, published this year in Columbia University Press. And they learn, you know, how to do innovation to reduce the basically increase the quality of air. But also the other outcome of the story was there were a number of, there was association created called Alarm Smogowe. In the beginning was only in Krakow, but then later spread across the country, and they created, this is something which I think is important, NGO community led by the kind of feeling they can do things, they started to act. So this is what's happened. And the very last, and I will conclude, it's a very short, very interesting case as well, that one person can also make a change. This is about the story of woman, the mother, who thought, that her children, they should get better education. Maybe they should understand better science. And she came to our university and she said, I would like to invite young children, 6-10 years old, to the university. You can imagine my president said, it's a joke. But then later they supported this, my faculty colleagues, and the young children, they started to come to our university, and this triggered a whole foundation called University for Children. Other universities in Poland opened door. And children, and the children, they have been very good, in asking questions. So they simply help with this development somehow. So they were able asking questions. I pick up, two, what are the feelings? Why sugar dissolve in the tea? And many, many others difficult questions. They help to create the curricula for those discussions, experiments children were able to do at the universities. But this was done by one mother, then a few mothers together, then other mothers across countries started to establish this kind of university for children with the help of universities. And then Agata, her name is Agata Vilom, she moved to Nigeria, and she started to work with children there, and she was able to help children in Nigerian schools with number of projects in the area of environment education, project-based learning, and she continues there. So basically you can see that experience she brought from one place, completely foreign to other one, was really nicely executed in other things. And this is just also following Dr. Benjamin's point, education is a part of the health. So thank you very much and for the invitation and speaking to you.
Thank you very much to Dr. Andre Jan-Ries for sharing with us the experience from Europe and how a difference could be made by a person, a local community, and a city. Thank you once again. 非常谢谢波兰的专家跟我们分享欧洲的经验哦。And next up to talk about integrating medical care and public health in Taiwan's national health insurance. Please welcome your speaker, Dr. Liang Yuchen, Director General, National Health Insurance Administration, Ministry of Health and Welfare, Taiwan. 那接下来呢，我们掌声有请卫福部中央健康保险署陈亮瑜署長來跟我們分享的主題是台灣健保如何整合醫療照護以及公共衛生。掌聲歡迎署長。
Thank you. Good afternoon, all the distinguished guests. It's my great honor to represent National Health Insurance Administration to give this talk to share our Taiwanese experiences of this system that has been running in Taiwan for 30 years. So this is the outline of my talk. I don't think I need this stage, so sorry. I'm a little bit taller compared to what people imagine. So this is the outline of my talk. I'll start to talk about the healthcare challenges. This year we have officially entered the super age society. And also the second part is I'm going to talk about how we embedded the data governance in our healthcare system. And the third one, I'm going to share a little bit experiences of how we combat and survive through SARS, COVID-19 using the National Health Insurance System. And then the expert will be my next speaker, Professor C.J. Chen. He's sharing more of his experiences. During these two pandemics, he's one of the leader help us survive these pandemics. And the fourth one is the perspectives, reflection, challenges for the future. So I believe you've seen this slide before. This is the 4 challenges we've been facing when Taiwan is officially entered the super age society. So that means that 1 out of 5 individuals in Taiwan is now age 65 and above. Of course, you can imagine that have posed tremendous financial challenges to our national health insurance system. It's a single-payer system. It's a mandatory insured system. Cover 99.9% of our citizens. So the age of the population changes. Of course, it will pose a threat to our financial structure. The second one will be the rising number of chronic illness and also cancer. So far, we have 23.5 million people in Taiwan, but those who are suffering from the chronic illness is about 8.5 million people. As you can imagine, it's like 1 out of 2 individuals, adult population, will be suffering from 3 highs, or COPD or asthma. Also cancer. Cancer is for the 43 successive years, is the leading cause of death in Taiwan. So we will also put a lot of resources into the cancer treatment. And the third one is new technology and new treatment is always expensive. So that accelerates the growth in our medical expenditures. The fourth is the thing that we keep talking about throughout this whole symposium will be the aging population and the low birth rate that will undermine the health insurance revenue. And we do need a more sustainable financial structure to support operation of national health insurance for the next 30 years. I agree with Professor Shu. He just mentioned about the threat this morning. And thank you for your honesty. So this graph illustrates the numbers affected by the 3 highs and also the share of the global budget. You will see, as I mentioned before, about 8.5 million people in Taiwan have chronic illnesses. About 3.2 million of them are suffering from diabetes, 5.2 million for hypertension, and 5.1 million have hyperlipidemia. So we do need to incorporate the health promotion into our treatment for 3 highs. If we look further to the health burden of in Taiwan, measured by Delhi, you will see the number 1, not surprisingly, will be cancer. It constituted about 20.26%. And the second will be the cardiovascular diseases, and the third one will be diabetes. However, if we look at the medical expenditures spent on 3 highs or 3 high-related comorbidities, complications, you will see it it's about 167.6 million NT dollars. It's about 1/6 of our global budget for the national health insurance. So that is why in our presidential office, we have launched a Healthy Taiwan initiative. There's a national project called AAA project, aiming to better improve the management of chronic illnesses. The AAA refers to, the first A refers to 80% of the 3 high patients will need to be covered by our big family physician program. So far, the number will be 61. We are trying to expand the service scope up to 80%. The second A will be lifestyle intervention. As we know that all the evidence have shown that 40 to 60% of the chronic illnesses worsen or occurred because of lifestyle. So our payment system are now still mainly pay for service. So we do need to incorporate lifestyle intervention into our treatment. So starting this year, August, we start to incorporate lifestyle intervention. We ask the patient to fill in the questionnaire for their diet, their exercise, their stress management, and trying to incorporate their lifestyle management into the treatment plan with their family physician. And the third A will be the mission goal for the chronic illness AAA program. It's called 80% needs to get a fair control. So this is the platform in our National Health Insurance database. Here are two interfaces. The first one will be the facility management interface. Here you will see the proportion of the enrolled patients. What proportion of the enrolled patients for certain clinic or medical institutions are under fair control and their data. The second one is for the case management interface. So for example, for our diabetes patients, we have the case manager following up their condition. So for the case manager, they will be able to look at the data for their patient, and also we offer the visual aid, so you will be able to see the change and the changes over time for their biochemistry profiles of these follow-up patients. So here comes my favorite part, so I'm from Taiwan. So people always tell me that Taiwan has AI in our name, and Taiwan has AI in our DNA. So we will launch the NHI card with the chip here in it in 2004. Taiwan produced 70% of the chips, 90% of the advanced chips in the whole world. So here we have starting from 2004, we have the National Health Insurance IC card. We have the last 6 treatment visits, your prescriptions, whether you have a catastrophic disease or not, because you can get a cheaper payment for your treatment visits. The consent for palliative care, DNR, or organ donation. That's our start, back at 2004. And later on, we launched the MediCloud in 2013. Now we have the medication, the surgical records, the vaccinations, and dental services. And I want to mention particularly the immunization. So here, you will have the vaccination data, so which is crucial to play the role in several significant pandemics, including COVID-19. So you know the proportion of your individual, your population, you have 1 dose of vaccination, 2 doses, 3 doses. So that's crucial as it's a mandatory and also single payer system. So basically that's the national data. NHIA, the MediCloud system, also plays a crucial role to save unnecessary medical expenditure and also to improve the patient security. Here you will see the duplicate examination on the left. It decreased from the 2.94 to 2.31 billion NTD after we start to launch the MediCloud system. And for the medication, it decreased from 2.41 to 0.78 billion. That's a 67% drop, not just for the safe or the unnecessary prescriptions, but more importantly, it's safer for our patients. For example, if you have duplicate sedative hypnotics, that may cause you to easily fall down or you have a respiratory suppression. So it's save money and also it's better for our patient safety. So in 2019, we also further launched the virtual IC card. We have 2004, the real IC card. Then 2019, we have the virtual one embedded in our My Health Bank is an app launched from NHIA. Here you will see the hospital will submit an access request during COVID-19 to each individual and to see that whether you will authorize me to see your data, and you say yes, and the healthcare provider will be able to gain the access in the cloud to see the medical history, the prescriptions, the allergy history for each individual, and using the telemedicine to see the patients. And we will be better prepared if the next pandemics come. And furthermore, we launched the e-prescription platform this year. in the eastern coast of Taiwan. Compared to the western coast of Taiwan, the medical resources are not as abundant as the western coast. So we are using the FHIR format to increase the interoperability. And also, if you are using this e-prescription, you can use the QR code in your mobile phone and to take the medication to the drugstore nearby you. You don't need to travel all the way to visit a hospital that is very far away. And it's all more eco-friendly, and also it's easier access for each individual living in the rural areas. So here comes the total solution of all the barrier-free services in the era of digital health. Here you will see you could register using the virtual IC card. Then you can see the doctor using telemedicine. Then you will use the e-prescription with the QR code in your mobile phone to see the doctor. And we have a very mature e-payment system here in Taiwan. So that will be the total solution. It will be paper-free. And you don't need to go out except for taking the medication from the drugstore nearby you. That will be launched fully, hopefully, very soon in the whole Taiwan. So far, it's in the eastern part of Taiwan. So that will probably be the last mile of a universal healthcare. When it comes to universal healthcare, and people talk about the success of Taiwan's national health insurance, the coverage is about 99.9%. It's high accessibility and very efficient payment system. However, we do have some urban-rural disparity. For the Taipei compared to Taitung, the lifespan disparity is about 9 years, I believe, lately. So we do need to enhance the equity through the digital health. So here you will see there's a doctor. We do have 24 hours of emergency room and the internal physician in underserved areas. However, we do not have sufficient specialists, for example, eye doctor, ENT doctor, psychiatrists in those underserved areas. How do we do this? We cover that through the telemedicine and by teleconsultation. So here you will see a doctor. He is consulting another doctor living in the city. So this is a doctor helping his patient in the Ali Mountain. So the eye doctor is using the telemedicine to help examine his eye. So National Health Insurance cover all the specialty consultation starting this August. And also we have launched an app called My Health Bank. So it's not just the case manager and the medical institutions could have the data. The patient, him or herself, could have their own data. We believe that if the patient has his or her own data, it will empower them to better manage their health. And health is each one's responsibility, not just physician's responsibility. We are shifting the dialogue from the medical paternalism to like someone is responsible for your health, and we are offering the help and the data that you need. So this is the AI-generated health education information. So based on our big data analytics from the NHIA, you will see that, for example, for diabetes, for example, you will have 6 different risk sets. For each different risk set, we will feedback you the health information that you need. If for the elderly, they will not be able to read their cell phone very clearly, we also have the audio app that could help you to read out all the information. Okay. Last but not least, we are trying to reach the goal of precision medicine. It's not just for cancer treatment, but also for chronic illness management. For example, for the payment system, we are now designing different types of payment system, not just from fee-for-service, but shifting the dialogue from pay-for-service to pay-for-value. So with 6 different kinds of risk sets, we will have different kinds of payment system depend on the comorbidities, and we call that value-based care. I feel a little bit humble to talking about this topic because CJ Chen is now sitting in the front line. But I would like to mention that national health insurance play a crucial role during SARS and also during COVID-19. Here is the app. You could see we are not just having the COVID-19 vaccination. We also have the screening records linked to the My Health Bank. So now the government will have the national data of the screening results and the vaccination results. And altogether, we will be better to think through it and make a better plan for anti-COVID or anti-any pandemics coming next. Again, I feel humble that I need to talk about hepatitis B and C, but here you will see that we have so many different programs for hepatitis. 40 years ago, the leading cause of death in Taiwan is hepatitis. Now it's out of top 10 cause of mortality in Taiwan. So we did pretty good job when it comes to hepatitis B and hepatitis C treatment. So National Taiwan Insurance, we have so many programs, and in each one of program 4 different years, we ask them to screen for HBV and HCV. And then later on, for the very expensive treatment, DAA, we start to cover it in 2017. I do know that not many other countries does not cover that very expensive treatment, but that helps us to reach the goal. So we are trying to eliminate hepatitis C by 2030, but we reached the goal 5 years earlier this year. And I believe CJ Chen, Professor Chen will talk about that later in detail. So this is the aging population. I talk about we are entering the super age society this year, but people have no clue how fast we are reaching the ultra age society. So with this speed, we will reach ultra age society by 2039. That is pretty much the situation in Japan. So we have to be well prepared for the transform of the whole healthcare system. So in a super age society, we have a lot of challenges, not just financial challenges. We also face the manpower shortage, particularly nursing manpower. It's a global issue. And also we are trying to overcome the urban-rural disparity through digital health, as I mentioned before. So one key word to summarize the future NHI roadmap, I would say the key word will be integration. Service integration, data integration, resources integration. The first integration will be service integration. Let me take one clear example. As we are now the super age society, our long-term care system has become very huge and a big burden for each family. So now we have a huge data set in the Department of Long-Term Care in the Ministry of Health and Welfare. So we are now trying to merge the medical service from the NHI and also from the service from the long-term care. In order to merge that, there are 2 things that we need to do. First of all, we need to integrate the data. So we want to see one individual throughout the journey, how much money that he or she needs throughout the hospital, and then how much money he or she needs when he or she is using the long-term care services supported by the government. That's rule number 1. Number 2 is we're trying to integrate the resources inside the hospital and the resources in the community. For example, for the elderly, there are a lot of resources are in the community, it's public or private from the NGO. So we are now trying to integrate these resources from the medical service and also for the NGOs and also from other communities, and to reach the goal of PPP that could be more patient-centered, person-centered services. That will be the all of my talk. Thank you all for coming, and I want to mention that I do appreciate the honest, sincere sharing from this morning. Thank you so much.
Thank you very much to Director General Liang Yuchen of National Health Insurance Administration, Ministry of Health and Welfare, Taiwan. 非常谢谢健保署陈良宇署长的精彩分享。Thank you so much. And coming up, we are going to welcome Dr. Jiren Chen, academician and distinguished professor, Genomics Research Center, Academia Sinica, Taiwan, to talk about elimination of end-stage liver diseases in Taiwan, the strategies and achievements. 接下来呢，我们就掌声有请下一位主讲人，中央研究院院士、基因体研究中心特聘研究员，掌声欢迎陈建仁院士。
Thank you very much for the introduction. It is really my pleasure and honor to give a presentation on elimination of end-stage liver diseases in Taiwan, strategies and achievements. And in this section, we are going to talk about the interplay of public health and national health insurance. And I would like to assure you that indeed, this interministerial collaboration is very important to achieve any kind of public health project. And as you can see on these slides, there's before 1995, there's a decline in mortality from stroke, heart diseases, and other chronic disease in Taiwan already before the implementation of this national health insurance. But you can see that mortality for malignant neoplasm still increasing until year 2000. And so this cancer is the leading cause of death in Taiwan, very important one. And if you look at this mortality rate of top 10 cancers in Taiwan from 1980 to 2022, and you can see there's a very rapid decline in liver cancer mortality since 2002. And we implemented antiviral therapy program in 2003 after the SARS outbreak. So you can see there's a rapid decline in mortality from liver cancer. And the reason for that, I would like to share with you some of the story. And we all know that both hepatitis B virus and hepatitis C virus are very important etiological factor of liver cancer in the world, especially in Southeast Asia as well as in the Sub-Saharan Africa. And this virus were identified by two groups of Nobel laureates. And in Taiwan, the first case control study of hepatocellular carcinoma identified that hepatitis B chronic infection is very important to cause HCC in Taiwan. In this slide, there's a case control study, 55 cases from Taipei Veteran General Hospital and 943 control from Zhuoyin Naval Base in Kaohsiung. And if we they tested the surface antigen, hepatitis B surface antigen as a sero marker, and 80% of cases are HBsAg positive, and control is only 15%, showing a relative risk of 23-fold. So dating back to 1971, published by Miriam Tong of UCLA, they found that indeed hepatitis B is a very important etiological factor of HCC in Taiwan. However, this is a cross-sectional case control study. And dating back to late 1970s, there are still medical research, U.S. Medical Research Unit 2 in Taipei. And the publicity, my mentor, when I was a master's student, he carried out a long-term follow-up study of more than 22,000 men in Taiwan. And as you can see here, among those who were hepatitis B surface antigen, more than 3,400 people, and there's the mortality from primary hepatocellular carcinoma as per 100,000 is 1,158. And this mortality for for surface antigen negative non-carriers is only 5, showing a relative risk as high as 223-fold. This is the very first paper in the world to document that virus is a very important etiological factor for human cancer. And Palmer considered that this is very important for us to help the people in Taiwan. So he carried out a study and published in New England Journal of Medicine. And you can see here, most of the carriers in Taiwan were born to mothers who were hepatitis B carrier, especially for those who were hepatitis B E antigen positive. Their baby, 85%, almost 90% will become the chronic carrier. So Palmer carried out a clinical trial in Taiwan, and as you can see on the right-hand panel, among the controls without the vaccination, the newborns after this 12 months of follow-up, 90% of them become the chronic carrier. However, for those who were vaccinated, the carrier rate is only 6%. So Palmer considered, wow, oh my God, this vaccine is really effective. So he urged our government to implement this, the very first nationwide infant hepatitis B immunization program in Taiwan. And we have to recruit the pregnant woman and test for hepatitis B surface antigen and E antigen. And all the data has to be computerized. So dating back to 1984, our Ministry of Health already have our computer system to try to save all this information, because for those infants born to E antigen mother has to get HBIG and vaccine. And for the others group, only receive the vaccine without HBIG. And we started this newborn vaccination since 1984 and up to 1986. And after 1986, all newborns get this vaccination. And you can see that a paper published in New England Journal of Medicine by Professor Zhang Meihui and my group. As you can see that for children aged 6 to 9, and you can see before the program, of the vaccination program, the instance of liver cancer, although they are quite small, but you can see it's 0.52 per 100,000 children. And for those born after the vaccination program, it's even lower. It's 0.13 per 100,000. And in other words, there's a 75% reduction in liver cancer of these children aged to 6 to 9. And after 30 years of the vaccination program, as you can see on these slides, there's a paper published in JAMA. And as you can see, for infant fulminant hepatitis, the sex-adjusted relative risk is only 0.03. It means that 99.7% of infant fulminant hepatitis has been intervened by the vaccination. So it's a quite significant reduction. With regard to the chronic liver disease mortality and hepatocellular carcinoma mortality for those who aged 5 to 29, you can see that around 90% of liver cancer of this liver cancer among vaccinated group has been prevented. So hepatitis B vaccination has become a necessary, is included in this expanded program for immunization in the whole world. Except recently, I was told that in the United States, HBV vaccination will be not a compulsory one, will be quite chosen by the parents. I'm wondering why. But for those who were not born, for those who born before the vaccination program, and they still had a very high risk of hepatocellular carcinoma. So we carry out a long-term follow-up of more than 23,000 men and women. And as you can see here, in our paper published in New England Journal of Medicine, we found that not all the chronic carrier of HBV will have the same risk of HCC. If the chronic carrier will HBeAg positive, then the risk will increase dramatically. In other words, we can triage the chronic hepatitis B patient to E antigen positive or E antigen negative, and because they have different risk of developing HCC. And in 2006, we also found that the serum HBV DNA level is another important risk predictor of hepatocellular carcinoma. And as you can see on these figures, the higher the HBV DNA level, the higher the risk of HCC. Even among the E antigen seronegative patient, they still have high risk. So we cause all these hepatologists in Taiwan are quite trouble. The reason for that is not only one factor determine the risk of HCC. Basically, you can see here, among the viral factors, E antigen sero status, elevated viral load, and HBV genotype are important. In addition to viral factors, age and hepatic inflammation reflected by elevated ALT, family history of HCC, alcohol consumption, and male gender are all related to hepatocellular carcinoma. And how can we consult with the patient if there are so many risk predictors for hepatocellular carcinoma? So we have used the AI system, and according to our long-term follow-up study, we developed this HCC risk calculators. We call this RICH-B calculators. If you know this age, gender, ALT level, E antigen positive or negative, as well as HBV DNA level, then you can come up with the risk score, and you sum up the risk score, then you can easily predict the 3 years, 5 years, or 10 years cumulative risk of HCC. And this kind of risk calculator is very helpful to provide hepatologists or physician to give the consultation, discuss the situation, disease situation with the patient, and decided whether the patient has to take antiviral therapy or have to take this regular liver surveillance. And then, as you can see that according to our research, we found that E antigen positive is important, HBV DNA level is important, ALT important. So we can further triage the patients into different groups. Some of them are recommended to receive antiviral, and some of them are just have a regular follow-up and so forth. So after the SARS outbreak, just as mentioned by Liang Yu, unfortunately, at that time I was health minister. Unfortunately, we contained the outbreak within quickly, within 28 days. And after that, a lot of hepatologists in Taiwan came to see me and said, CJ, it's the time for us to launch the antiviral therapy program for chronic hepatitis B and chronic hepatitis C. So from October 2003, we started our national therapy program. And as you can see, by 2023, we already treated using antiviral more than 273,000 chronic hepatitis B patients and more than 196,000 chronic hepatitis C patients. And for hepatitis C patients, more than 170,000 are treated by direct antiviral agents. And you can see here, as you can see that for the year 2003, there's a vertical blue line, and you can see that there's an age-adjusted rate of chronic liver diseases, hepatocellular carcinoma, as well as hepatocellular carcinoma instance, all declined very rapidly after year 2003. And even analyzed by birth cohort. And we also found that in addition to vaccination program, there's an antiviral therapy are also useful. So as you can see on this slide that if we compare the mortality before the implementation of antiviral therapy, that's 1999 to 2003, and then we compare with 2014 to 2018, there's a 26% reduction in chronic liver disease and cirrhosis mortality, and 50% reduction in HCC mortality. So antiviral therapy is also very effective. And this is this liver cancer mortality. And we found that we continuously to implement the antiviral therapy, maybe Taiwan can reduce the liver cancer mortality by half in 2015, or by 30% in 2030, maybe. And for the reduction of 50% liver cancer mortality in Taiwan by 2050, because we do know how to prevent, how to screen, and how to treat the liver cancer. So we implement the vaccination program and also antiviral therapy program. And as you can see on the next slides, we, in year 2020, and this is a WHO target for viral hepatitis elimination. The first one is 3 doses of hepatitis B vaccination by 90% by 2030. But in 1989, we already achieved the goal. And the prevention of mother-to-child transmission of HBV, the goal in 2030 is 90%, but we already achieved that in 1989. Because we implemented vaccination program much earlier. For the blood safety and injection safety, we also reached the goal. And for harm reduction, we also reached the goal in year 2005. Then the last but not the least target is the diagnosis and treatment of HBV and HCV in Taiwan. So we can see that for HBV, it might not so easy to do, but for hepatitis C elimination in 2030, we consider, yes, we can do it, and even 5 years earlier. So we have a Taiwan hepatitis C policy guideline for 2018 to 2025. And the core strategies is precision public health, continuum of care, and localized care delivery. And the policy direction is the therapy, spearheads prevention, screening, supports therapy, and prevention secures the outcome. And through this kind of effort, we try to increase the chronic hepatitis C treatment coverage and reduce new infection of chronic hepatitis C infection patient, and also reduce the chronic hepatitis C related mortality. And we have an action plan for that, and this including the very important one in our National Health Insurance Administration. We definitely have to provide an adequate budget. We provide 1.7 billion that's in 2018, for 8 years, the budget for the treatment using this DAA and lowering the barrier of access to care and so forth. So once we have this kind of action plan, so we implemented yearly, year by year, and we also have a nationwide screening program for hepatitis C and for the general population and also for the special population and also for comorbidity population. And this is one of the, this is the last slide I'm going to share with you that by now, that's the almost the end of 2025, and we analyzed the data. As you can see, the Taiwan status in 2024, the diagnosis rate of chronic hepatitis C infection, according to World Health Organization target, is greater than 90%. And at the end of 2024, we already reached 93.9%. And for the treatment of patients with chronic HCV infection, the target is 80%. Or higher, and Taiwan reached 92.8%. For self-medical injection and self-blood transfusion, we already reached the goal, 100%. And the injection set provided to each person with injection drug and per year is supposed to have 300, and we already reached 419. In other words, if there's a very good inter-sector collaboration from the National Health Insurance Administration, from our Center for Disease Control, as well as from our Health Promotion Administration. Then we work together, and more importantly, have active participation of the people in Taiwan. Then we can achieve the goal of 2030 for the elimination of HCV in 2025. With that, I would like to thank you very much for your attention.
Thank you very much to Professor Zheng Chen for the very informative talk. 非常谢谢陈先仁院士哦。我们分享台湾如何消弭末期肝病，有什么样的策略以及成果。Thank you once again. All right. And our last speaker in the plenary session 1 is Mr. Joseph Kusing, Senior Fellow of Switzerland Results for Development R4D. 那我们这个场次呢，最后一位主讲人是瑞士 R4D 的资深研究员，同时呢，也是前世界卫生组织全民健康覆盖健康融资政策以及系统司的协调专家。And he's going to talk about health financing in European countries, patterns and nuances. 要跟我们分享欧洲国家的健康融资的现况。Ladies and gentlemen, please welcome Mr. Joseph Kusing. 掌声欢迎。
Thank you. Thank you. And this is a real honor to be here. A number of people who were not from Taiwan were commenting on how many times we've been here before. For me, that's easy. This is the first. One reason why is, as I think I was originally introduced, I've been working for WHO for the past 30 years. And so having retired from there 2 years ago, I now have the opportunity to come to Taiwan in a personal capacity, which is great. And also very important because I work in the field of health financing, and I know how much, in a sense, the world has lost by not having adequate sharing of your experience with the rest of the world, and so much to be learned from here. The other question I wanted to address up front, and I don't know if you can tell from my accent, is why is an American talking about health financing in Europe? The reason, frankly, is for 10 of those years that I was in WHO, I was the lead advisor on health financing for the European region. So I have at least some background, although I still didn't pick up the accent. But I did broaden my appreciation for universal coverage. So I framed the title, just to come back in this way. Part of what I want to convey is that many health systems on the surface or by label seem to be very different. And you do have differences across health systems. But in fact, in important ways, there's also been a convergence of certain key features. So that's what I'm going to try and convey, particularly around when we discuss kind of broad system design, as well as some specific features like the role of voluntary health insurance. I then want to draw on some really path-breaking research from some of my former colleagues in WHO's European office in Barcelona, where they've done a lot of work on the issues of protection against financial hardship from health expenditures with ways of measuring catastrophic expenditure and really looking at the policies that seem to work better or worse in protecting populations against those payments. So with that as introduction, just to come to a few descriptives. Maybe I will go back and put my glasses on. I'm in between. I'm going to show you some numbers, and just to explain this a bit, this shows the distribution of health spending by revenue source, broad revenue source according to the Global Health Expenditure Database. The ones in green, which are in darker green, general budget revenues, and lighter green, social insurance contributions, those are the public sources of funding, right? The funding from mandatory sources. And as you can see in Europe, spending is overwhelmingly public for the most part, although as you go towards the right-hand side of this chart, you have some concerning higher levels of out-of-pocket spending. Here, the pink part, which is voluntary health insurance or voluntary prepayment, is rather small. And that's also one of the messages, that basically in Europe, voluntary health insurance is quite a small share of the total. Now, if we look at the data in a different way, which is by financing arrangements. So in the system of health accounts, you can look at data by source or the revenue sources, but you can also look at the data in terms of the health financing arrangements through which money flows, okay? And that you see in the dark green here, a set of countries that are overwhelmingly flowing directly from the budget to providers. So you have systems wherein the entitlement to contribution is based on residence or citizenship, whereas in the lighter green, you have the entitlement, what might be traditionally called social health insurance arrangements, where entitlement to services depends on a contribution that is made by you or on your behalf. So you do see some mix, and again, you see a relatively small role for voluntary health insurance. But what I do want to point out in looking at this issue of social health insurance, one of these messages, and really a nuance, is the idea that the source of funds is not the system, okay? We used to talk about saying, well, countries can choose between, a British-style NHS or a German-style social health insurance. In fact, if you look at the countries that have money flowing through social health insurance arrangements, a substantial amount of that comes from general budget transfers, okay? And it's changed over time, but for example, in France, it's now and what this is saying is the social health insurance manages about 80% of the money in the system, and only about 51% of its revenues actually come from insurance contributions. The other half is coming from general budget transfers. In some other countries like Hungary, 3/4 are coming from general revenue transfers, okay? So in a sense, and you see this range of the extent to which systems get these transfers. This matters because if you're making entitlement to benefits dependent on contribution, then someone has to pay for people who are unable to contribute, or for issues around adverse selection and trying to reach self-employed people, so that even mandatory systems are de facto voluntary in that sense. So in high-income, upper-middle-income countries in Europe, they manage this through general revenue transfers. This also matters, and I think this is kind of one of the issues that has come up here and perhaps may be relevant. When we first started looking into this issue, a lot of the concerns with over-reliance on wage-based taxation for healthcare had to do with what you've talked about here, which has to do with demographic change, right? And if you have a smaller share of the population that is of working age, a lot of the focus of attention is that's going to mean higher health costs and so on in the future, but it also has implications for the revenue mix as well. If a smaller share of the population is of working age, you can't rely so heavily on wage-based contributions. You need to diversify to other types of taxes, other revenue sources as well. So there are real revenue implications of these demographic changes as well. The second point about progressively delinking entitlement to contribution, in a sense, it depends very much on your public policy. If your public policy, and many countries have a constitution that include a right to health care or a right to health coverage. Not my own country, of course, but many countries do. Where that's the case, then treating it as simply an employee benefit is really not consistent with that. So many countries have moved towards this more delinked approach, either fully or again through general revenues to at least soften that link and meet that obligation to cover everyone. But this is like everything in the financing of health systems. This is not easy. Countries are facing a lot of fiscal pressures, and in Europe now much more competition for things like defense spending, given recent actions by the US government. So that is having implications. And as countries, and Martin McKee was talking to this a bit, and it's not unique to any one country, right? There are a lot of internal debates taking place in all countries about the rights of non-citizen residents, right? So whether they are migrants and refugees, and policies in Europe have flipped back and forth depending on who's in power as to the extent to which non-citizens have entitlement to services and under what conditions. So that's part of what's happening. In terms of voluntary health insurance, in general, it is a small share of overall spending, but in some countries, it does reach high population coverage. And you can see here, and especially in countries, again, like in France and Slovenia, which I'll come to in a moment, where the voluntary insurance is one part of a complementary financing arrangement in which there are large co-payments in the publicly funded part, and the voluntary health insurance covers those, okay? Elsewhere, where it says here, for those countries where it offers more choice, reduced waiting times, and so on, the bottom line in all cases is the more people with voluntary health insurance, the more issues of inequality you will have, because of course those with that coverage will have greater access than others. But just a bit more on France and Slovenia, where the voluntary health insurance is not simply a reaction to long waiting times or other things, but explicitly filling gaps in the system. So it has long been a concern in France that this arrangement was really leading to inequalities. So over many years, government stepped in and either eliminated the co-payments for people below a certain income level so that they wouldn't need that, or increasingly subsidizing the purchase of that complementary insurance. So that in fact, while it's private and voluntary, almost everybody has it, and government steps in and funds a lot of it as well. And finally, after many years back and forth in Slovenia, they did take a decision a couple of years ago to simply slightly increase what's going to be funded through their social health insurance and eliminate the complementary voluntary health insurance. In other words, to reduce that large co-payment obligation that was there. So I think the issue is that a lot of countries have recognized the problems of voluntary health insurance and taken steps to try to mitigate that through various ways. Okay. The next thing which I wanted to talk about in terms of system design, and again relevant here, is the idea of multi and single payer. And what this is showing is that when you look at on the surface, you see countries with different arrangements as to how they organize insurance, and whether that insurance is called insurance or whether it's like in this bottom group of countries, Sweden, Spain, the UK, and so on. It's not called insurance, but it's a decentralized subnational geographic fund, in a sense, for each territory. And you only have a few truly single-payer arrangements for Estonia, Hungary, Latvia, Lithuania, where there's a single agency, okay? But when you look a little bit more deeply, and especially when it comes to provider payment, that even countries, and I'll just take where I'm living now in Switzerland. Switzerland has about 60 or 70 private health insurance companies. There's a law that everybody must be insured, and if you're below a certain income level, you get a subsidy for that. But in fact, when you go to the doctor, it is a highly detailed fee-for-service reimbursement system. They have a very powerful medical lobby and a very, very powerful medicines lobby as well. But when you go to your provider, there's not a different form for each insurer. It's a single unified national fee schedule for services that are in the guaranteed package. So you don't have the kinds of administrative costs and burden that you do in a multi-payer, multi-insurer system where they each have their own data systems, their own payment rates, and so on. So they've been able to manage in several countries, really the ones in green here, that even when they have multiple insurers, having a single payment system, which I think is the case in Japan as well, right? You have multiple public insurance societies, but there's a single fee schedule. And in that sense, you can do a lot to reduce the administrative costs and the gaming behavior that otherwise takes place in the context of multiple insurers. Okay, so to summarize all of this, you do see certain patterns in design. So you tend to have in the pooling side either a single national pool or geographic pool, or insurance pools, if there's multiple insurers, but even those tend to be mitigated or almost kind of virtually national pools because of risk adjustment and other factors that makes them similar. In practice, again, because many countries recognize both the problems of multiple payers, and I think if they knew more about what you're doing here, the real opportunities of having a strong single-payer agency and a unified national database, and the extent to which that can really provide the engine for making your system better in a sense. And as that is recognized, I think we'll see even more convergence towards this single payment system. And then in terms of voluntary insurance, yes, they're financially small, shrinking in some cases, especially on the complementary side, but I do think there's a concern as countries face budgetary pressures that the supplemental kind of bypassing insurance, jumping the Q type, may grow as well, and that's one of the pressures to watch. All right, in the second half of what I'm going to talk about are what we've seen in terms of policies to ensure effective protection against financial hardship. And this really relates to policies on what my colleagues call coverage design, but really co-payment design choices. These are data from various recent years, a number of studies, countries that were part of this study, looking at both out-of-pocket expenditures, financial hardship, and health financing reforms. And on the horizontal axis is out-of-pocket spending. I hope my acronym is okay. I always went with OOPS, which is for out-of-pocket spending. It's also to convey that it's a bit of a mistake. So this is as a share of current spending on health, so how large are out-of-pocket payments. And here, based on their analysis, are the percentage of households that experience catastrophic health expenditure. And as you might expect, there's a relation, right? The more out-of-pocket, the more catastrophic, but you do see also a lot of variation, okay? And policy people like me really like variation in these graphs because it means that it's not just an accounting problem and actually policy matters and we can continue to have jobs even after we retire, because getting these things right is important. And so just to show this here, for example, in Spain in 2019, had about 20% of spending was out-of-pocket payment, similar to Estonia and Poland and Italy and so forth. But they had very different results in terms of this. So the question is, what are the kinds of policies that even with higher levels of out-of-pocket spending can protect against catastrophic expenditures? How to get those right? Now, one can do, and there have been several books written about this, but I'm going to summarize first by describing the problem a little bit further. What this is showing for, again, the various countries that have been studied is in the lighter blue, the average in the countries of the share of households experiencing catastrophic expenditure. And in the dark here are, in the same countries, that experience for people in the poorest 20% of the population. And so this approach really captures the fact that this hurts the poor more than the average household in society. A lot of this is methodological in a way. I mean, it's intuitive, of course, but basically the way that things had been measured in the SDGs, and this work is part of why that was changed, was that if you're simply looking at out-of-pocket spending as a flat share of your overall health consumption expenditure, you're not accounting for the fact that poorer households have less capacity to pay, have more that they need to devote to basic needs, right? So this has a basic needs adjuster, in a sense, and that's coming into the SDG measurement now. It also is an issue that richer people tend to use services more. So if someone is too poor to even visit a health facility, they will have zero out-of-pocket spending. And you could say, well, they were protected by their poverty. But it's not a good thing, obviously, right? So you want to be able to capture both the service use side, but also an adjusted measure of catastrophic expenditure that does account for capacity to pay, which is why we're actually here getting this type of result that's more intuitive, right? That it's a bigger problem for the poor. So here is what we observe in practice, and this is really where the policy messages are. So again, on the vertical axis, and apologies to this side of the room, I'll do this here. So this is the share of households that experience catastrophic health spending. And these are countries grouped in different ways. These countries with much higher and much worse performance in terms of catastrophic expenditure tend to use percentage co-payments. So you get a bill, it says that it's 100 whatever, and we cover 80%, and you have to pay 20%. And it can sound good unless you have a chronic illness, right? And you need regular use of medicines and so on, and then 20% and 20% and 20% is a lot, right? And in a sense, the implicit policy position by charging a percent is that the sicker you are, the more you're going to pay. And that's not really consistent with the idea of offering protection against financial hardship. Some of these countries do have some exemptions and some overall cap, but the countries that do well over here tend to do a few things. They either use an overall, a well-implemented exemption based on income, if they have the administrative means to do that, exemption from payment, or a specific cap, like you have out-of-pocket expenditures, but it will only go up to a certain share of your annual income, and then everything else is on us. They tend to use, in a few cases, a fixed rather than a percentage copayment. So, each visit to the doctor is €5. It's not dependent on what your diagnosis is or what treatment you get. And then in those few cases, Croatia, France, and Slovenia, and I talked about France and Slovenia, they offer this protection with complementary voluntary insurance. So overall, kind of the message is with this lower financial hardship, let me see if I'm getting this right. Yes, that you want to exempt people from all copayments, not just for certain conditions and so on. You apply the caps again to all and not say just for cancer care or just for this disease, but not that disease, because it's the household, not the disease, that's paying, right? And then stronger caps for people with low incomes. And over here, the problems of caps not linked to income tend to then at richer people, and charging a percentage of the bill is kind of an accounting solution, but not consistent with policy objectives. So my last slide, just to summarize all of this, which is that we see systems in Europe that look a bit different, but there is this kind of convergence towards a single payment system, keeping voluntary health insurance small. It's also evident that how you design your coverage policies, your copayment policies, can actually strengthen or worsen financial protection, but there are still major challenges, like there are everywhere. The ability to maintain and sustain high levels of public spending on health is coming under pressure. Really designing protections against financial hardship for people with chronic illness is a challenge everywhere in the world, especially around outpatient medicines. That's a key issue. And maybe the biggest, almost philosophical question is that all of these great achievements in your country and in some other countries are driven by the idea of social cohesion and solidarity, and that is currently under great threat from countries in places around the world. So a real challenge as to whether you would maintain, and they're able to maintain their consensus around core values. So thanks very much. If you want to learn more, I just put up a couple of sites that I drew on for this presentation, but thanks very much.
Thank you very much to Mr. Joseph Kuzing, Senior Fellow of R4D. Thank you once again. Thank you. Or maybe Joseph, you want to wait on the side for the panel? Thank you. 我们非常谢谢我们这个场次呢，总共有4位主讲人哦，每一位都非常精彩的分享. Thank you once again to all 4 speakers in this session, Plenary 1, and to play of Public Health and National Health Insurance, including Dr. Andre Yang Rees, Dr. Liang Yu Chen, Dr. Jianren Chen, and Mr. Joseph Kuzing. 再次谢谢我们4位主讲人哦。那接下来呢，是我们综合讨论的时间。我们等一下呢，也欢迎现场的贵宾可以提问哦。等一下呢，如果有问题的贵宾都可以举手，等我们的工作人员将麦克风递给您之后呢，先介绍一下您自己，之后再看要针对哪一位主讲人来提问。All right, ladies and gentlemen, now we'd like to move on to the panel discussion. And for that, we'd like to welcome our moderator and 4 speakers back to the stage. So let's welcome our moderator, Deputy Minister Jingying Lin, Dr. Andre Yang Rees, Dr. Liang Yu Chen, Dr. Jianren Chen, Mr. Joseph Kuzing. Please take your seats on the stage. And if you have any questions, feel free to raise your hand and wait until our staff pass the microphone to you. Introduce yourself and which of the speakers you want to ask questions to. All right? 好的，那接下来呢，我们就把时间交给场次的主持人林静怡次长。Over to our moderator, Deputy Minister Lin.
Thank you. Thank you for all our speakers sharing their valuable insight to us. Once again, thank you for your sharings. And now we have 15 minutes for an open discussion. So if anyone have questions to our speakers, please, I think you feel free to share your thought or have your hands. Here? Okay, please. Middle ladies here. Please,
工作人员
microphone.
帮忙递一下麦克风。
第一下麦克风。
Yes, to Professor Boris.
Yes, please.
Thank you. Thank you for all of you, and thank you especially to the economists among us, living in Switzerland like me, knowing that 69 health insurance companies can be quite a headache. My question to you, as being an economist who studied European solidarity-based systems a lot, I always have a question. Why is it that the US is not even considering the idea of a population-wide universal health coverage system? It is for me a miracle. And you, I think you are the only person who is in both systems who can answer that. I'm really, every time, out-of-pocket paying in Switzerland is high, creates inequities, but the US system creates more than inequities. So my question, what is behind this resistance to go to a system that has been proven worthwhile in a lot of places in the world?
Shall I? Sorry, are you asking why I moved to Europe or live in Switzerland? I mean, it has been considered. In fact, historically, when the US was developing the Medicare and Medicaid programs, there was, I think, an intent that, there's no reason to stop at age 65, that we would want to take the next steps. But a lot of opposition came out, and I think, and Professor Shu mentioned a lot of the opposition to the national health insurance here in the early years. That opposition was, in the US, was from the medical, again, the medical community and so on. And again, over the years, Medicare became accepted, but extending Medicare below age 65 seemed somehow to be something alien, right? And there's no obvious reason why that should be the case. What I think is an important, there have been important developments and a lot of piecemeal developments that are very expensive, and of course the Affordable Care Act went a long way towards getting more people covered. But one of the messages we used to give when I was in WHO to any country is that, you can't just spend your way to universal coverage. And so unless you can get a handle on the expenditure side of the system, you're not going to be able to really sustain progress. And I think a big problem in the US that is extremely difficult to deal with, and I've seen it a little bit in other countries like in South Africa, but certainly in the US, is that when so much of this huge amount of money in the health system, and just as a sideline also, I know this from my time at WHO, that over 40% of the world's health expenditure takes place in the US, okay? So that is a remarkable thing. When you convert everything to dollars and so on, how much of that actually goes to healthcare as opposed to preventing people from getting healthcare, as opposed to administrative costs, as opposed to a whole range of other things, is not so clear. But when you have all of this corporate interest in the system, you have a very hard time reconciling public policy objectives, like moving towards universal coverage, with maximizing return to shareholders. And a lot of that return is driven by segmentation and fragmentation, and that there's a really poor alignment between private interests and the public interest. So, why haven't politically people come together to deal with it? There have been bits and pieces. There's been attempts in some states, but the size of and this is, I mean, other people here live in the US, I'm just an expat now, but you know, the amount of money to be lost, given how much has been gained, seems to be able to motivate sufficient political lobbying and other efforts to keep that from happening. Whether it will continue, I don't know.
Thank you. Have any questions to our speakers? Yes, yeah, there. Left side. The lady. Thank you, please.
Good afternoon. I am Merla Rose Reyes from the Philippines. And my question is for Professor Chen. Sorry for the pronunciation. We would like to, in PhilHealth, we are now developing a benefits package for liver cancer. But there's also newly launched benefits for liver cancer screening. But the overall goal really is to lower the case of liver cancer in the Philippines. So from your presentation, I learned a lot. And I would like to know if you would recommend PhilHealth to pursue the development of the benefits package for liver cancer, and also if there is also if it is also important to develop a benefits package for liver transplant. Would these interventions lower the case of liver cancers in the country? Thank you.
Okay, thank you very much for your question. With regard to liver cancer, I myself consider that prevention is the most important. And I know that in Philippines, you do have hepatitis B vaccination program. So that's one thing that's very good. And the second thing is the early detection of this chronic viral hepatitis. So there's the screening of hepatitis B and hepatitis C carrier status is very important. And that's to my knowledge that in Philippines, you also have a high prevalence of chronic hepatitis B. And the third thing is that with regard to the liver transplantation, I would say this is the last strategy to do it. That means that we can do nothing to help the patient unless we have a liver transplantation. And liver transplantation is quite successful in Taiwan, either in Kaohsiung Chang'e Memorial Hospital or in Taida National Taiwan University. There's a liver transplantation operation is very successful. However, there's a limitation that the donation, the liver donation, organ donation is not popular here. And of course, if there's relatives, first-degree relatives can donate this liver, then part of the liver, then we can do that too here in Taiwan. But the best way, I would say, from the prevention point of view, preventive medicine point of view, I would consider to prevent the liver cancer is the first choice, rather than let the patient go to the end stages and doing the liver transplantation. It's quite expensive, although it's effective, but it's very expensive, yeah.
Thank you. More information about in Taiwan. Actually, we have a very high coverage for prenatal screenings and postnatal screenings for a newborn. So that is another that I think very efficient, efficient that to have a screenings for newborn and women to aware about their infection conditions and vaccination. Professor Zhang, you have questions, sir?
Some question on the
A question here?
Yeah. Thank you. My question is for Professor Cousin. You're talking about the balance between co-payment and financial protection. And the Taiwanese community, especially the medical community and the business community, loves co-payment very, very much. Okay. And it has been the key the most important policy advocate since the previous president, okay? And the current Minister of Health, Shi Buzang, he is thinking about raising the co-payment for people go to medical center directly. He just announced it a couple weeks ago. Do you have any advice for him or for the government? Thank you.
I'm here, listening.
I mean, I guess the question is, where does the love, what's the source of the love? I mean, in the sense of, is it because it provides a bit of extra money, or that basically it's kind of part of almost a cultural attribute of the system? I guess the question is, some of the countries that I showed that are doing well on catastrophic expenditure, it's not that they have eliminated all co-payments. They structure them specifically in a way to limit their harmful effects. And I guess this is the question. I do think there is something of a, going all the way back to kind of, in part, why there's such a field as health economics was, I mean, basic economics says that if you raise the price, people should use less. The problem in healthcare is that, it's because of all the market failures and imperfections, it is providers that drive utilization, especially after the first contact, much more than the users. So hoping that you're going to get a big result from a policy on co-payments without doing anything else, like if you still have fee-for-service reimbursement and you raise co-payments, all you'll do is, yes, it's more fuel on the fire, it's more money in the system, but it doesn't change things fundamentally. So if you want to drive efficiency gain, the main issue is how will you influence provider behavior more directly and get those incentives right? And then you can think about, okay, if we want to do things like, in some countries, we want to strengthen primary care, we make that free, but if you self-refer to a specialist, then you have to pay something. That could be part of a package if you're doing the other things as well. But on its own, I wouldn't expect much. And all of the evidence internationally says that, co-payments, or user fees, whatever you call them, they do dissuade utilization by poorer people more than richer people, but there's no evidence that somehow it's only unneeded things that are dissuaded, right? It's, people are not, it's not like raising the price of bananas or tomatoes where I can make a pretty good judgment as to whether I want that, if I want to pay that for not, So this is a different issue. So anyway, all of that to say is, I think that co-payment, a refined co-payment policy can be part of a package of reforms, but co-payments alone, I would say no.
Thank you. We still have time for one question here. So many, okay. he had, this gentleman have raised hands.
Thank you, Professor Chen. On the liver cancer story, striking results are you seeing there? And I would like your thoughts on the aflatoxins. They have been considered between 5 to 20% of the liver cancers are due to aflatoxins. And while it's striking the results you're seeing here in some low and middle income countries, including Guatemala, liver cancer has become the second cancer killer in the country. Obviously, you can argue that we have very low vaccination rates, but apparently that's not explained the whole story, and apparently aflatoxins are part of the big picture. Any comments on that?
Okay, I think this is a very good question. We did carry out a molecular epidemiological study to test this aflatoxin in human serum, and there's a positive rate of aflatoxin exposure in Taiwan is quite low. However, we still have in some area, some people have a higher aflatoxin, and we found that aflatoxin exposure have a synergistic interaction with chronic viral hepatitis B and C. So for those who have a chronic hepatitis B patient with aflatoxin, their risk of SCC will increase. But aflatoxin per se is not a major risk factor in Taiwan, but in Sub-Saharan Africa and also in some of the Eastern Asia, Southeastern Asia, aflatoxin still has to be paid attention to. So it's important to have a monitoring of aflatoxin contamination of the food. Yeah, it's definitely very important. Thank you.
Thank you. I think we still could have 5 minutes, okay? Here, and next you here, okay.
Thank you. Thank you all for your presentations. My name's Tom Roth. I'm a family physician from the United States. We apologize for all the confusing things going on. We're getting beaten up this afternoon. So a question for Dr. Liang Yu Chen. As you know, in the United States, we're all in on value-based care. We've gone fairly far down that road. But what we find is that the administrative burden has increased for nurses and doctors to do this additional work. The incentives also have increased. But it's led, we think, to some increased burnout, which can lead to workforce challenges and other things. So I was going to ask, in your experience, if you're starting to see some of these issues and what you might do to approach them.
Thank you for your question. I believe if I remember that correctly, the administration fee for the U.S. Health system overall will be 33%. In Taiwan, we are all government official or working in a public officers, so in Taiwan is 2%. Actually, up to this year, it's less than 2%. So that's overall, that's the difference. In Taiwan, we do develop several programs for pay for value-based payment program for diabetes, for hepatitis B and C, and also for breast cancer. Definitely, there will increase a little bit of the administration costs and efforts from manpowers. However, we do believe that will lead to better clinical outcome because, as I showed the data, with the super-aged society, the cost, the medical expenditures on the 3 highs and will continue to grow. And pay for service does not lead to better clinical outcome, they say that. So we are learning from over the world to design our pay-for-value program. And one big strength of our National Health Insurance Administration is that it's a mandatory system, 99.9% of the coverage, and also it's a single-payer system. So basically, we have all the data. We don't have different players, then the data does not talk to each other. And that is what happened in a lot of Western countries with extremely high GDP. But within my knowledge, the data does not talk to each other, so it's difficult for state government or federal government to design certain program that works for all people. And it's easier to do so in Taiwan. So that's why I keep saying that we need to take advantage of the data and do our analysis and do our math very well to further design the pay-for-value program. Thank you for your question, and feel sorry for Americans who are sitting in the room today.
Okay, we have a final question here, okay?
Thank you. Good afternoon, everyone. I'm Andre Chell, Director of Health Policy Planning and Research in the Ministry of Health and Wellness, Belize. As a follow-up to the data governance question, my question is for Dr. Liang Yu Chen. In my country, we're currently moving towards the digital health transformation, and we know that data governance and management is very important, right? So I'd like to hear on the critical success factors that Taiwan has had when it comes to having that strong interoperability of data to ensure that the sharing of data and how Taiwan uses the National Health Insurance Card to capture the data that is needed. I'm sure that everyone here, we can all learn from the best practices of Taiwan in this regard. Thank you.
Thank you for your question. Thank you. Thank you for your question. That put me to think a little bit. And I think, as I mentioned, the significance of the data and how we utilize the data to design our public health policy, including in SARS and also in COVID-19. So I think one big thing that we ask our people to put their data inside the government, the crucial role there that is missing in this discussion is trust. Why do Taiwanese people trusting in the government? They put their 99.9% of the data in our administration. First of all, you need to have very good cyber security. So we do a lot of fundamental digital infrastructure investment throughout the 30 years, as I mentioned, the national health insurance, IC card, MediCloud, and no cyber attack event, no major one, throughout the 30 years, which is really difficult. That's rule number one. Number two is a very transparent payment system. So basically the medical health professionals, the provider side and the user side believe in the government, believing on the financing, also believing in the data that's putting inside the administration. The third is that regardless of your country, whether you have a multi-payer system or a single-payer system, I always say that one thing that we all believe in is to invest in the digital infrastructure for the data. So, for example, for the United States or for the Switzerland, so the multi-payer system, then your data could link it to each other. So it's easier for the government, either state or the central government, to decide for better public health policy for them, including the example that our Professor C.J. Chen just mentioned, our history, our battle throughout the hepatitis B and hepatitis C, and hope that will help for your question. Thank you.
Thank you. I think, we really thank you for all our four speakers, and thank you for your listenings. I will close the sections here, and once again, we have a big hand for all our speakers. Thank you.
Thank you very much. And can I invite our moderator and all four speakers to stand up? Next, Deputy Minister Jingying Lin would like to present certificates of appreciation to all speakers in the plenary session 1. 我们请次长稍微往前一步，我们在中间呢来颁发感谢状哦。我们请各位贵宾，我们请次长往前。All right, firstly to Dr. Andre Yang Rees. 好，我们看向前方的镜头合照一下。Have a look at the camera in front of you. Thank you very much. And Dr. Liang Yuchen, 接下来我们有请陈亮宇署长。And then Professor 简仁琛，陈建仁院士。And Mr. Joseph Kuzing. And lastly, a group photo. Can I have all four speakers stand on both sides of Deputy Minister Lin? Let's have a photo together. Give them another big round of applause. Thank you so much. All right, ladies and gentlemen, it's time for us to take a coffee break, and we have refreshments and also beverages ready outside. Please. The refreshment and also coffee and tea are ready on your left-hand side, okay? On your left-hand side. 那请各位贵宾呢，从您的左手边的出口。我们在外面呢准备了茶点以及饮料，请各位贵宾享用哦。Let's do a 10-minute break, ladies and gentlemen. Feel free to bring the food and also drinks into the auditorium. We'll be back by 3:45 for plenary session 2. 那各位贵宾，等一下呢都可以把茶点、饮料我们带回您的座位享用。不好意思，我们稍微有一点延误哦，所以我们短暂休息10分钟，休息10分钟，等一下3点45分，我们再回到会场，谢谢。 如果有贵宾呢遗失耳环的话，请来找我们。Lost and found, everybody. We had a earring here. Okay.各位贵宾，如果您有遗失耳环的话呢，请等一下来找我们的工作人员，谢谢。 好，我们下一个场次呢，等一下要正式开始了。我们是请工作人员也协助引导一下还在场外我们取餐的贵宾，准备其实可以把这个茶点跟饮料都拿回会场内来享用哦，谢谢。All right, everybody, we are about to begin in a few minutes. Feel free to bring some food back to your seats. Thank you. All right, people who are still outside, can you hear me? It's time to be back for plenary session 2. Thank you very much. 好，我们请各位贵宾呢，我们准备回座了，谢谢。 All right, everybody, please return to your seats. Our speakers in plenary session 2 are ready to go, so please take your seats. Thank you very much. 各位贵宾，我们场次2的主讲人已经准备好了，请大家准备回座，谢谢您。All right, and before we begin, we just found an earring here in this section. All right, we just found an earring here in this section. So anyone missing an earring, please come to us. Thank you very much. 那如果有人遗失耳环的话，我们刚刚还在这一区有找到一个耳环哦。啊，是署长的。Okay, lost and found. Okay, welcome back, ladies and gentlemen. We're now in plenary session 2, focusing on sustainable development of national health insurance. 那接下来呢，是我们大会场次的场次2，要聚焦的是健保的永续发展哦。那话不多说，我们首先就有请场次的主持人为我们开场介绍主讲人。And now to open the session and introduce our speakers, please welcome your moderator, Director General Dr. Liang Yu Chen of National Health Insurance Administration, Ministry of Health and Welfare to the stage. 让我们掌声欢迎卫生福利部中央健康保险署陈亮宇署长，我们的主持人上台，为我们开场介绍场次的主讲人。
Thank you. Good afternoon. Thank you for staying to this session. It's my great honor to represent National Health Insurance Administration to be the moderator of this session. This session is about sustainability of national health insurance. We celebrated 30th anniversary of our NHI, but also we have a lot to think about the financial sustainability of SDG and also of how we transform our healthcare system in facing the super age society. Please, next. Next, please. Thank you. So in today's plenary, we have 4 distinguished guests from domestic or also internationally. Allow me to introduce them all in once, and then later on we can enjoy the whole session with their excellent speech. The first one will be Professor Chen Zhihong. He's an honorable professor of cardiology at National Cheng Kung University. He's also the former vice president of China Medical University. He's also served as the vice president of Asia Pacific Society of Cardiology. He has rallied the medical professionals to jointly form the Healthy Taiwan Initiative. Following President Lai Ching-te's inauguration, he serves as the deputy convener of the Healthy Taiwan Committee. Professor Chen emphasized the committee's goal is to shift its focus toward preventive medicine and chronic disease management, rather than traditional disease treatment model, with the goal of extending the healthy lifespan of the general population. In Taiwan, so far the lifespan is 80 years, and also the unhealthy years will be 8 years. Today, he will share his insights on improving national health policy and in promoting healthier, longer lives. Our next speaker is Mrs. Zheng Zongmei. Mrs. Zheng is a renowned expert in health policy, with a particular focus on cross-national comparisons of health system, health reform, and health technology assessment. Her late husband, Professor Owe Reinhardt, was a distinguished health economist who also contributed significantly to the 10th and 30th anniversary of our National Health Insurance Forum. offering valuable insights on Taiwan's national health insurance reform. As Taiwan's national health insurance celebrates our 30th anniversary, we are privileged to have her today to share her expertise and reflections on the journey and also the future perspectives. Next, we are honored to have Dr. Ole Johan Baki. Is that correct? If correct me if it's not okay. He's currently serving as the CPME president for the term from 2025 to 2027. Dr. Becky has played a key role in supporting Taiwan's international health collaborations, offering valuable guidance to enhance Taiwan's engagement in global public health exchanges. Today, we are fortunate to have Dr. Becky here to share his insights on the future public health policy internationally. And also, there are a lot of lessons that we can learn from each other. Our last speaker is the guest from Korea, Dr. Ki Sung-yong. He's the president of the National Health Insurance Service of the Republic of Korea, appointed July 2023. Prior to this, he led Korea's COVID-19 response as the director of the CDC headquarters. We are honored to have Dr. Yong here to share his insights on how Korea is adapting its healthcare system to meet the challenges of an aging population, and also share the experiences of the digital transformation of the Korean healthcare system. We are deeply honored to have the domestically and internationally 4 renowned experts here to share in this forum. Let's give our big round of applause to them. Thank you.
And thank you very much to our moderator, Dr. Liang Yu Chen. Thank you. 非常谢谢我们主持人陈良瑜署长的开场介绍哦。And next to talk about Healthy Taiwan Initiative, the role of national health insurance, please welcome our first speaker in this session, Professor Zhihong Chen, Professor Emeritus, National Cheng Kung University, Taiwan. 那接下来呢，我们就首先有请场次的第一位主讲人，国立成功大学医学院名誉教授陈志宏院长，为大家介绍健保在健康台湾计划当中所扮演的角色。我们掌声欢迎院长。
Thank you. Mrs. Moderator, Dr. Chen, distinguished guests, ladies and gentlemen, good afternoon. It is my honor and privilege to be here to attend this very important health conference. And as we celebrate, this is the 30 years anniversary of Taiwan's national health insurance. However, we must look ahead to the future. So I think we must transform to the next chapter in Taiwan, that is Healthy Taiwan. Healthy Taiwan initiative has been proposed by Dr. Lai Ching-te, who ran in the presidential election in 2023. And the Healthy Taiwan initiative was one of the key commitments for Dr. Lai to be a president. And allow me to give you my personal story. This group photo has been taken in 1995. That year also, we launched the national health insurance in Taiwan. And in 1995, when I served as the department head of Zheng Gong University Medical Center, that is in southern part of Taiwan, and this medical center is a brand new medical center at that time and full of energy and hope. Among the healthy young physicians, Dr. Lai Ching-te stood out. So you can see that this is me, young. And I serve as the chairman of internal medicine, and this is Dr. Lai Ching-te. At that time, he was the chief resident of internal medicine and specialized in nephrology. However, one day, Dr. Lai came to me and said, "Sir, I want to devote myself to public service, to go to political instead of practicing medicine." I was not surprised, But I say, in this case, you have chosen the road and the road not taken. And I remind Dr. Lai, two things. You must complete your specialist training first, and then don't forget your commitment to serving the people. And until now, he kept both promises very well. And on May 20 last year, he was finally elected to be the first physician president of Taiwan. And 1 month later, he has established 3 important committees at the presidential office. That is the National Climate Change Committee, Healthy Taiwan Promotion Committee, Whole of Society Defense Resilience Committee. All the members of this committee, 80% of the members of the committee are from, non-governmental employees. They are key opinion leaders from different kind of communities. And these 3 committees are interplayed very closely. And Dr. Lai, President Lai, served as the chairman for all 3 committees. As a longtime mentor, I was invited to serve as the deputy commander for the Healthy Taiwan Promotion Committee. And Taiwan now faces major demographic changes. That is a rising aging population and a declining birth rate, and rising numbers of chronic disease and cancer in Taiwan who require long-term continuous care. And also new drugs, new devices, new technology on the market, while effective, however, may increase medical expenditures. And almost 100% of population in Taiwan covered by national health insurance. So aging population and low birth rate will undermine health insurance revenue. So we must take some consideration to consider to transform our healthcare system and reform our national health insurance. This slide shows you the top 10 causes of death in Taiwan 2024. Cancer, always the #1 killers in Taiwan for almost 43 years. However, if you look at the other causes of death, #2, heart disease, #4, stroke, #5, diabetes, #6, hypertension, and #9, kidney disease. All these causes of death have a common risk factor, that is the 3 highs. Poor control long-term hypertension, poor control diabetes, and poor control hyperlipidemia can cause organ damage and cause the morbidity and mortality. So last year, the total number of cancer, the total number of deaths caused by cancer is about 54,000 deaths. However, if we put all the other 5 causes of deaths, that is the total number of deaths caused by the 3 highs, that is 61,000 deaths, is even greater than cancer deaths. So the message is very clear. We must not fight with cancer. We must also pay equal attention to the preventable chronic disease, that is the 3 highs. Over the past 18 months, our committee is working very hard, and we had a national forum for Health Taiwan every year. And so far, the committee, under the leadership of President Lai, we have defined 5 pillars for building healthy Taiwan. #1, National Cancer Program. #2, 888 Program to improve management of the 3 highs. #3, mental health resilience for all citizens. #4, building a new healthcare system. #5, secure the sustainability of the NHI. And all these 5 pillars has action plan, has budget, has KPI. So we were working based on these pillars. Pillar 1, National Cancer Program. Our goal is very simple. That is to cut the cancer deaths by 1/3 by 2030. we are trying to enhance early cancer screening for some particular cancers. We will implement focus on genetic testing and precision medicine to improve the outcome. And number 3, we will establish another cancer new drug fund that is $10 million. This is independent of the global budget because we want to make some additional budget to support improvement the treatment of the cancer patient. Any cancer patient should not lose their life simply because they cannot afford the new effective drugs. Pillar 2, so-called 3.8 program. Right now, we know that if we control the risk factor through the target, we can reduce the mortality or morbidity for patients with 3 highs. But however, right now in Taiwan, the control rate of hypertension to the target is around 50% only. And control hemoglobin A1C to less than 7% for diabetes patients is less than 50%. So we must try our best to improve the treatment or the outcome for patients with 3 highs. The so-called 3.8 program is in 8 years, we must identify and recruit 80% of patients with 3 highs into the care network. And among them, 80% of these patients should receive lifestyle intervention, such as nutrition, counseling, regular exercise. However, the most important, 80% of these patients must control their risk factor to the target and to have a better outcome and reduce the mortality and morbidity. Pillar 3, strengthen mental health resilience for all citizens. Taiwan aims to triple the capacity of mental health service by 2028. We want to expand community health centers. We will increase capacity of addiction treatment. We want to expand the mental health care into primary care clinics. So without mental health, there is no true health. So this is also a very important part for us to work for this point. Pillar 4, a sustainable healthcare system must have 3 elements. That it should be smart healthcare, green healthcare, and resilient healthcare. The government is fostering to private and public cooperation to build up a new system. So our government offer a Healthy Taiwan Sprout project. This is a 5-year project. The government offer 50 billion in 5 years for health organization to propose their project and focus on 4 areas. Number 1, how to improve a better working condition for healthcare professionals. Number 2, we will emphasize diverse talent training program. Number 3, integrating smart healthcare technology to healthcare. Number 4, we will fostering a green, resilient, and sustainable healthcare system. Smart healthcare is everywhere in Taiwan, from AI-assisted imaging, diagnosis, management of the hospital, and go to anywhere, go to every stage of people. So the smart healthcare will not only in hospital, where from hospital to community and to homes. And in Taiwan, we have an advantage for healthcare development because we have strong technology in this regard. And we have innovative industry in Taiwan, and we have a strong support from government to develop digital healthcare. However, there are some challenges demand to be solved. That is information security, data fragmentation, and AI ethics. Hopefully, the government develop so-called AI new top 10 constructions. This can promote the enhancement of information security, data integration, and AI regulation in the future in Taiwan. We are trying to establish a solid foundation for AI and move forward to global leadership. President Lai has also proposed a green growth strategy, and the goal of government is to reach the net zero emission by 2050. So the core value of the strategy is driven by twin transformation. That is the green and the digital. So healthcare system must go to green hospital and digital healthcare. Why is healthcare should be green? Because the climate crisis is also a health crisis. Because of the global warming and the greenhouse effect, so many extreme weather events happen everywhere in the world, and Taiwan is no exception. So we must face some extreme weather events in Taiwan, and during the disaster, we must have a very resilient healthcare system to face the changes. So we are trying to build in climate-resistant healthcare facility. We will establish early warning risk assessment. We will support the continuity of essential medical service. And we will train some climate competent workforce and governance and financing for resilience, community engagement and partnership. And also, all the hospitals should be moved forward to a green and a low carbon operation in the future. This is Taiwan, this summertime, severe typhoon, heavy rainfalls will damage everywhere in the world. So this is a disaster we should face in the future. During the disaster, in response to the disaster, the law of National Health Insurance Administration is very important. So NHIA offered comprehensive disaster relief measures. We will support continuity of service. We will open medical station in some disaster area using with telemedicine or without. We must have a flexible access to care and prescription. We must have a single service window for assistance, including medical service, and premium relief and support for affected citizens. And all the medical expense will be supported by government during the disaster area. Pillar 5, how to optimize the sustainability of NHI in Taiwan. We know that we have 3 challenges for NHI. That is finance, stability, resource allocation, and drug supply. But among these challenges, the most important is the finance. So our government has paid attention to this. So in this year, we have a high estimate of the global budget. So in 2024, the total amount of global budget up to 928 million NT dollars. This is the biggest increase in the history. However, our government offered another budget from the public service budget that is 18.1 million NT dollars. Put together, all the medical expenses is increased. The real growth rate is 8.13% in comparison to 2024. It is likely that the next year, the budget will up to 1 trillion NT dollars. So this morning, Professor Shu had said that the way we practice will be driven by the payment system. I'm totally agree. So in 1995, the NHI offered the so-called provider-centered disease care. However, during the time, we shifted peacefully, smoothly to global budget, DRG. And right now, we moved to the value-based payment and some integrated care. So the healthcare system will be shifted from provider-centered disease care to patient-centered healthcare. Disease care, the care is fragmented, and pay-for-service may affect the finance. But in the patient-centered healthcare, the care is integrated. We will focus on prevention and some lifestyle intervention. That is the health management, and the payment system will shift from pay-for-service to value-based payment, and they will be powered by AI and digital tools. So this is a whole picture of the healthcare reform in Taiwan. This is a people-centered life course healthcare. We were from very good family physician program with value-based payment program to focus on the preventive care, to disease care, chronic disease management. However, when patient is become hospitalized, we have acute inpatient care and to better post-acute care and home health care and hospice. So this is a whole picture for the people-centered life course health care. So this will be continuous, coordinate, and compassionate patient care system. We are now moving toward this goal. So, ladies and gentlemen, Healthy Taiwan is not only a slogan. Healthy Taiwan is now translated into national policy. However, I think Healthy Taiwan is a promise. It's a promise to every person in Taiwan where we have a happier and healthier life in the future. So I thank you for your attention, and thank you very much.
Thank you very much to Professor Zhi Hongchen of National Cheng Kung University. 非常谢谢国立成功大学医学院陈志宏名誉教授精彩的分享，谢谢。And next to talk about Taiwan's national health insurance at 30 experiences and lessons for global health policy, we'd like to welcome Ms. Zongmei Zheng, Health Policy Research Analyst, Princeton School of Public and International Affairs, Princeton University, USA. 那接下来呢，我们有请普林斯顿大学公共与国际事务学院卫生政策郑宗美研究员跟大家分享台湾健保30年对于全球健康政策的启示以及可供借鉴之处。Ladies and gentlemen, please welcome your speaker, Ms. Zongmei Zheng. 掌声欢迎。
I already did something I'm not supposed to do. Hello, everybody. Please allow me to also say how happy I am to be here for this very special occasion. And I'm sorry that Uwe Reinhardt is not able to be here because he would have been so very, very happy to see the development and growth of Taiwan's national health insurance 30 years after establishment. So I think I will talk about lessons, the experience and lessons from Taiwan's NHI from looking from the outside and share my observations with you. So first, I thought we'll do a very simple conceptual framework of national health insurance systems, the choices that governments can make in organizing its national healthcare system. This is especially so for countries, emerging market countries looking to establish universal health coverage. And then we have a very quick look at Taiwan's national health insurance, and then just, reflecting a little bit, taking stock 30 years of the national health insurance, and then the more focused on lessons for global health policy, and then just I conclude with some observations. So first of all, options in national health insurance systems. The national health systems have many dimensions, but two are most important, most relevant in organizing a health system. And the first one is who owns and operates the facilities that produce and deliver healthcare. Here we're talking about the delivery system. And the second dimension is who owns and operates the financing of healthcare, which includes health insurance. How do you pay for health insurance and healthcare? I'm going to show you a taxonomy, which is a taxonomy of health systems used around the world and Taiwan's choice. Okay, here it comes. This is a taxonomy. So look at the two dimensions that are marked in red. In terms of financing of health insurance, you have basically three large categories different ways to finance. You have social insurance, and within social insurance, you have single-payer systems and multi-payer systems. And then second category of financing is private insurance, which is based on actuarially fair financing, very often based on the health status of the insured. And the third category is no health insurance at all. That's out of pocket. It's or oops. Borrowing from our friend Joe. Yeah, now within social health insurance, that is based on ability to pay principle. Then you look at the ownership of providers. You have you can have government ownership, which are government hospitals. You can have private non-for-profit hospitals, or you can have private commercial providers. These are, a lot of them are just private clinics, which are small businesses in an economy. And Taiwan made a choice in 1990. So how did Taiwan decide which options to go for? Oh, I should say that the letters in each of these cells represent options. See, the government can pick, so to say, for my country's health insurance system, I would like to pick A, but mix it with some H, and then mix it with some M and O, because it's difficult to all at once organize and finance fully a national health insurance system. So Taiwan made this choice. In 1990, it made a choice to go single payer because it wanted to have its system based on ability to pay, based on the principle of equity. And for delivery system, Taiwan went for all three. They have government-owned and operated public hospitals. They have private, not-for-profit hospitals, because for-profit hospitals are not permitted in Taiwan. But Uwe Reinhardt will tell you that there's very little difference in the behavior of for-profit and not-for-profit hospitals. So do not be misled by the different names that these hospitals are called. And also private commercial. See that there about 99% of all clinics in Taiwan are private. Now, I will just have a very quick word on the genesis, the history of Taiwan's national health insurance. You already heard a lot of it. Here is just some, I wanna just drill, into your memory that it was really impressive that Taiwan did what it did. Because at the time, the government made the decision to build the national health insurance system in 1986. Why? Why that particular time? At that time, there were 41 million uninsured and 13 social insurance programs, each covering a different population. But at that time, there was a confluence of several factors in Taiwan that were conducive for the government to undertake a major, expensive policy initiative like building a national health insurance system. Now, what are these conditions? One is, this is most important because you need money to build a health system. Taiwan has had robust economic growth for decades, very often in double digits. And then there was a strong popular demand for better health care. In every country, when a country becomes wealthier, people want more and better health care. And the third is political competition, because Taiwan is about to abolish its martial law, which got abolished in 1986. So opposition party was rising to rival with the long dominant one-party system. So there was that competition and leadership, and we have seen that Taiwan benefited from very, very wonderful leadership to have the system it does now. Now, here's the next question: why and how Taiwan choose a single-payer approach to universal health coverage? Why? Because they have all these systems, right? Remember the taxonomy with all the cells? You can go public, private, single-payer, multi-payer, or commercial health insurance, or no insurance. So, but why did Taiwan decide on single-payer for it? Well, here, there's a Chinese proverb, 饮水思源. For those of you who don't speak Chinese, it means that when you drink water, think of and remember the source the water came from. Taiwan, just by a sheer stroke of luck, had 3 necessary conditions met all at once during the planning stage that prompted it to make the decision to go single payer. Those 3 conditions are a right man at the right time and in the right place. And here is that right man. I say this is because he is a Princeton economist, Uwe Reinhardt. He was serving as a senior advisor to Taiwan's government during phase 1 of the NHI planning. He recommended in 1989 in Taipei at a supra-ministerial meeting a single-payer system to the government, which was officially accepted in 1990. I think, Bill, you were there at the very same time. Because Reinhardt told the government that he believed that a single-payer system can best achieve the government's policy goals. And we will look in a few moments what those policy goals are. So there was a big bang, and then followed by 30 years of the national health insurance. See, in June 1990, the construction of the NHI began once the government adopted Reinhardt's single-payer recommendation. And then March 1, 1995, less than 5 years later, NHI implemented, and overnight, 41% of the then uninsured population became eligible for health insurance. And then, okay, from 1995 to 2025, that's 30 years, NHI saw many challenges, including several financial crises. Each time, the able, dedicated, and hardworking government officials in charge, and this is a point I cannot overemphasize, the NHIA directors, the Ministerial of Health and Welfare ministers and their staff, and of course, on up, there was a premier and the president. They shepherded NHI through the crises with reforms. So, looking back on the 30 years of this program, so how far has the NHI come? What did it do? Here, we look at the government policies at that time when they were planning the program. Equity in access to healthcare, 2, cost containment, and 3, quality improvement. So how has the NHI achieved? Has it achieved those objectives? What do you think? We'll take a very quick look. Equity. Coverage, 99.9 by now, I think everybody really remembers, stuck in your mind, 99.9. And a lot of it is also because of mandate. It's necessary if you want to achieve universal health coverage. It is absolutely, it's a necessary condition, mandate. And there's guaranteed issue, that's a second mandate, regardless of employment, health, or socioeconomic status. And the NHI is affordable. The premiums are very, very low. And then the government have subsidies for low-income households and particular populations like veterans, students, etc. And then a very important point is they have a national uniform benefit package. It's the same benefits for everyone, regardless whether they're rich or poor. President Ma Ying-jeou, I remember, once said that, you know, the child of a president gets the same care as a poor, or vice versa. Actually, the poor child gets the same care as a president, own child. And then there's access protection. First of all, there's excellent access. It's very easy. There's no big waiting times, okay? And then they have a special program that brings care to residents in remote, mountainous, and offshore islands. Now, controlling costs. How did Taiwan NHI do? Here is a graph that I took government data and made this graph for you. You can see the blue line is growth in national health expenditure, the growth rate, okay? And then the black line is a national health expenditure as a percentage of GDP. From 1991, 4 years before the NHI, to 2023, that's the latest government data. And we see that in the years before the NHI was established, the health spending growth was in the double digits. 1 year, in fact, in 1992, growth was 28%. That's just, it's out of this world, right? So you can see from 1995 on, health spending stabilized and came down, but then it started to go up again, and the government panicked at that time. And so from that time on, from 1998 through 2003, the government brought in a global budget system, which consisted of 5 sectoral global budgets. One for hospitals, one for clinic, one for dental care, and one for dialysis, and one for Chinese medicine. 5 introduced in different years. And you can see that spending growth really stabilized, okay? And then it's been below, you had the 2023, the growth was only 3.62%. So cost containment has been highly effective, I would say. Here, I have this graph to show you growth in national health expenditure in select OECD countries and Taiwan in the 10-year period. You can see that countries have different national health expenditure growth curves, the line. And how did Taiwan do? Taiwan, of all the OECD countries and Taiwan is not part of OECD, but you can see that the health spending growth was basically level, flat. Whereas other countries have seen the slope is upward trending, with the United States being the highest growth, right? Because this year, we're spending 17.2% of GDP on healthcare, when the OECD, the average spending in OECD countries is 9%. And Taiwan, the latest 2023 spending data as a percent of GDP is 7.5. But The 7.5, I think, is very recent. Before the most recent past 2 years, Taiwan spending as a percent of GDP is in the 6.5% range. And then they got some extra money left over for money not spent managing the COVID crisis because they were so successful with the COVID crisis management. They have among the lowest number of cases and the lowest mortality. When I make graphs showing how Taiwan controlled COVID, I make a bar graph, right? The United States is usually on the top, the most number of cases and the highest number of deaths. But Taiwan is at the bottom. Sometimes you can't not even see it. It's so little, that bar. And here you can see where Taiwan stands in terms of national health spending as a percent of GDP relative to OECD countries. You see? Taiwan spends, I go back. Yeah, the OECD average 10.5%. That went up a little bit from 2000 from the 21 data, okay, which was 9%. It went up. Maybe because economy slowed, so that the proportion of health spending appeared to be bigger. America is 17.2, and then Taiwan 7.8. And health system quality improvements, you all heard a number of that, so I would just say that NHI is super user-friendly and is understood by all. I just want to point out, though, in terms of administrative efficiency, which is a benefit that Reinhard told Taiwan that you will discover this and you will love it for a single-payer system if you choose it. Administrative cost is less than 1% of the total budget spent on healthcare, okay, the global budget. It's the lowest compared to OECD countries. And then the National Health Insurance Administration has a staff of 3,013. Okay, they run a whole system for 23.8 million Taiwanese plus foreign residents. I dug this out in red. You see that a United States private health insurance company, United Group, it has a staff of 450,000 that runs health insurance for 50.68 million Americans. Can you see the difference? It's shocking. So there are other notable features of the Taiwan's health system beyond the original policy goal that the government delivered to the public. Generous benefits. We have a friend from the Philippines who designs the benefit package for the Philippines. So here they have inpatient, outpatient. What makes it truly outstanding is Taiwan covers dental care, which a lot of national health systems do not offer. Okay, it's separate. You have to pay very often, etc. Free choice of providers. There's no gatekeeper. Easy access, I already said that. Short waiting time for common procedures. High utilization that you heard Vice President Chen talk about. There are no limits on visits. You can go 3 times a day, 5 times a day if you can manage, to different providers. But then there is a co-payment, but it's very moderate. There are caps, ceilings, and exemptions. And in terms of population outcome, life expectancy went up. You saw some numbers on that, and amenable mortality went down. And NHI also has made some very impressive digital transformations. I'll quickly run through them. And this is because the NHI invested in health IT early on to drive efficiency. And it has made a number of IT innovations and digital transformations, and here's a laundry list of them. See, you can see from 1995, they started with a paper card that recorded 6 visits, that's it. And then you have to go to the government to get a new card for the next 6 visits. And then in 2002, they introduced the NHIC card. I think it went into full operation January 1, 2004. I remember that from Minister Li Mingliang. But then they went 10 years later, they introduced Pharma Cloud, which keeps track of prescription drug use, and MediCloud, which is electronic medical record. And then in 2014, they introduced My Health Bank, which is a full personal electronic record. In America, we do not have that. I'm still looking for sheets of paper that says, what did my mammography say, or what did my lab say? I don't know my cholesterol levels. I don't know any of this. But in Taiwan, they can just consult their My Health Bank and get a full view of that. It's really, it's magical. And then lastly, they have this, they further advanced the MediCloud. Now, they initiated the medical image. All the images made by providers are uploaded to the cloud, and any provider anywhere in Taiwan can access that cloud when it sees the patient. Because remember I said patients can go anywhere, right? So if you go to a different hospital, that different hospital's doctor can just look at your full medical history in the MediCloud and treat you based on that, okay? So with all this that the program gave the public, what is the public satisfaction? This is interesting. See, from 1995 to 2024, you can see it started at 39% and then continued to go up, go up, go up. And interestingly, during the 3 COVID years, the satisfaction rate went up, okay? And now it's at 92% satisfied. This is very impressive. I can only think of the Danish system where the satisfaction is also in the 90s. But no other health system has this kind of public satisfaction rate. So what are the lessons from Taiwan for global health, especially for emerging market economies aspiring UHC? I would say that the most important lesson from Taiwan is if equity and social solidarity, these two objectives, equity, social solidarity in access to healthcare were fundamental goals of a healthcare system, the single-payer system provides an ideal platform for achieving these goals. I wrote this in my written statement for the United States Senate in a public hearing on what America can learn from other countries' health systems. I was invited to be the lead witness at that hearing, and I wrote about single-payer systems, including Taiwan's, and this is the first point. I made many points. This is the first point I said. And Taiwan's experience has shown this to be true. And other important lessons, you heard a lot of them already. Good cost control. Effective control of total health spending, not just by sector, but total. And you can do that because the government as a single payer has a monopolistic market power vis-a-vis providers. That's very important. And then you can see that, protects households from financial ruins, and you pay premium, and you can choose instead of tax finance. The UK NHS is tax finance, but Taiwan relies on premium financing. And then it has a lot of market features too, the single-payer system. So don't let people tell you that single-payer system is government takeover of medicine or socialized medicine. It's not true. In Taiwan, there's competition among providers. Money follows the patient. And the insurance is fully portable. However, it may lead to rationing by queue. There are waiting times for expensive treatments because of limited resources. And here, I just want to say that I want to point out that with all the strength that I've mentioned of single-payer systems, exemplifies in Taiwan's national health insurance, there is a weakness. The major weakness, which is the Achilles heel of single-payer approach, is underfunding. Because with it comes consequences, and these are the consequences. Financial instability, I think VP Chan mentioned that, because historically the NHI expenditure outweighed revenues, and there's slow introduction and long waiting time for expensive treatments. And then there's rising oops or out-of-pocket payments, 38% now in 2024. So this leads to erosion of equity and quality. So my question to Taiwan is Taiwan's national health insurance evolving, albeit slowly, into a two-tier healthcare system? Is this what you wish for or what you would tolerate? And then, of course, there's workforce shortages, low doctor and nurse population ratios. So here I just share my concluding observations. Taiwan has attained remarkable achievements in health policy in 30 years of the national health insurance. You all heard this, different organizations rank Taiwan's healthcare systems at #1 in the world, but has major challenges, which you also heard. Aging, rapid aging, it's now a super aged population, and there's rising public demand for more and better coverage for high-cost medical technology, and there's underfunding. But one can reasonably argue that, certainly I strongly argue that, Taiwan's rich economy, it's got a GDP in purchasing power parities per capita of $84,000. This is according to the International Monetary Fund in 2025. Taiwan, so based on this, I say that Taiwan can afford to and should spend more on healthcare, in particular on healthcare services in short supply. For example, high-cost cancer treatments, long-term care, nursing, you name it, health technology assessment, etc. It is a matter, I argue again, that it's a matter of Taiwan's willingness, not Taiwan's ability to spend more on healthcare, that will write the next chapter in Taiwan's healthcare. It is important that policymakers everywhere, but Dr. Chen is one of them, the head of the National Health Insurance Administration, to recognize that these windows of opportunity do come along once in a while for major health reforms. One may be on hand in Taiwan, maybe a question mark perhaps instead of period, because now in America, our American President Donald Trump wants Taiwan to spend 10% of its GDP on not healthcare, on military spending, okay? But the government revenue as a percent of GDP is only about 14%. And Donald Trump wants 10% of that for military. So there's a real question, a fight, a competition between different sectors for this pie. Thank you so much.
Thank you very much to our speaker, Zhongmei Zheng, for her very in-depth and insightful observation. 我们非常谢谢郑宗美研究员非常深入的观察以及分析哦，再次谢谢。All right, and coming into our next talk, healthcare workforce challenges and solutions. 那接下来呢，我们下一场聚焦的是健康照护人力的挑战以及解放。Please welcome your speaker, Dr. Ole Johanbach, President of Standing Committee of European Doctors, Comité Permanent des Médecins Européens, CPME Belgium. 接下来呢，我们就掌声欢迎我们的主讲人，欧洲医师执行委员会的主席。Yes, Dr. Ole Johanbach.
Distinguished ministers, excellencies, colleagues, and friends, good afternoon. It's a great honor to address this year's Global Health and Welfare Forum on behalf of the Standing Committee of European Doctors. I'm grateful for the opportunity to exchange experiences and perspectives on advancing sustainable and equitable health systems. Where should I point to? Thank you very much. For those who do not know our organization, CPME, the Standing Committee of European Doctors, is a non-for-profit organization representing national medical associations across Europe. We are composed of 37 most representative associations in Europe. We cover more than 1.7 million doctors. I will try to reflect about how the medical profession in Europe are part of both the challenges and the solutions we are dealing with today, or rather in our times. In reflection of the experiences of the COVID-19 pandemic, which showed the value of European solidarity and joint action, and with a view to present and future challenges, CPME has reflected on key lessons learned and future messages to European policymakers. We have summarized these in a health check for Europe, which represent our ambitions for the next European Parliament legislature to continue building the European Health Union. As you can see, our number one priority is tackling the health workforce crisis. There's been long-standing inadequate political prioritization of the healthcare workforce in Europe, which has led to decades of chronic underinvestment. This has led to widespread shortages across Europe, particularly in certain medical specialties, such as primary care, as well as severe geographic imbalances. Many healthcare systems also face persistent understaffing. The World Health Organization foresees a shortfall of around 4.1 million healthcare professionals in Europe by 2030. When we look at who makes up Europe's medical workforce, two demographic trends stand out, both of which highlight better planning is urgently needed for sustainability. Firstly, more than 1/3 of doctors across European countries are expected to retire within the next 10 years. This proportion rises to 40% or more in at least 12 EU countries, with some, such as Bulgaria and Italy, expecting over half of their doctors to retire within this period. Secondly, emphasis on work-life balance is changing, and systems can no longer rely on doctors working excessive overtime. Rather, part-time work is becoming more common. At the same time, women, who represent a little over half of the medical workforce in the EU, this will increase in coming years. In Norway, for example, where I come from, 75% of all medical students are women. There have been 50% since the last 40 years. However, workforce planning systems often fail to adequately account for differences in working patterns, including the increase in doctors who wish to work part-time. Many planning models still rely on headcounts rather than full-time equivalent measures, which provide a more accurate picture of the available medical capacity. Increasing demands for healthcare also adds pressure on the workforce, with aging population living with multiple chronic conditions. Also, younger patients are showing differently behavior, seeking more health services than previously. We also cannot ignore the lasting impact from the COVID-19 pandemic, which further exacerbated delays in elective procedures. The accumulated demand from these delays remain a major driver of rising healthcare needs across Europe. At the same time, evolving patient expectations place additional demands on doctors, from faster access to care to clearer communication, greater responsiveness, and more choice. These are challenges we have heard this morning that we share with Taiwan and other countries. Poor working conditions and workforce shortages drive younger doctors abroad or out of the profession, eroding medicine's appeal as a lifelong career. Studies have already demonstrated that there is a significant number of doctors who already plan to leave their hospital and some to leave the medical profession altogether. We also now note that the interest in starting a career in the health sector and in medicine in particular has declined in around half of OECD countries between 2018 and 2022. Shortages of doctors and other healthcare professionals also force the remaining workforce to face excessive workloads. CPME keeps underlining that overworked doctors experience both physical and mental exhaustion, leading to burnout, a key factor driving doctors out of the profession. And also, it puts in addition the patient security at stake. Violence and verbal abuse against healthcare professionals has been on the rise since the COVID-19 pandemic, with devastating consequences for mental and physical health for healthcare professionals. These safety concerns can make their jobs more stressful and dangerous, further contributing to discontent. The WHO reports that up to 38% of healthcare professionals suffer physical violence at some point in their career, and many more are exposed to verbal and online abuse. However, CPME has seen that there are still many gaps in data collection. We therefore recently supported the WHO Europe in a survey on doctors' and nurses' mental health, which has shown very concerning developments, such as 1 in 3 doctors and nurses reporting symptoms of depression, and 1 in 10 experiences passive suicidal thoughts. Violence has a highly negative impact on the socio-psychological well-being of doctors and only further fuels the rising levels of burnout experienced by healthcare professionals in their workplace. Protecting doctors' safety is essential to uphold the quality of care and prevent burnout. CPME calls for healthcare professionals to be protected from violence by establishing an effective Europe-wide reporting and support mechanism for victims, as well as the implementation of violence prevention programs and the enforcement of existing laws. In response to these challenges, several key solutions can help strengthening and sustain Europe's health workforce. Firstly, to ensure sustainable financing of health systems, governments need to prioritize investing into prevention. Investing in prevention and effective management of chronic diseases reduces future health expenditure and strengthens systems resilience. Preventive measures yield long-term returns by improving population health and freeing up capacity of crisis response. Public health legislation such as on tobacco control, air quality control, regulation or other measures further supports prevention efforts and improves population health. Promoting health literacy and awareness of healthy behaviors also helps reduce the incidence and preventable diseases, and the EU has an important role to play by investing in research, innovation, and evidence generation to strengthen prevention strategies. As we heard earlier today, strong primary health care is the cornerstone of resilient and sustainable health systems. Strengthening primary care helps coordinate services, meet most health needs in the community, and reduce unnecessary hospital admissions through effective triage and referral pathways. Moreover, modernizing medical curricula is also essential to align medical education with changing population needs and healthcare delivery models by strengthening training in general practice, community care, and preventive medicine. I'm not the only one to point out this today. EU funding programs such as the Recovery and Resilience Facility and Regional Development Funds could be better aligned to address healthcare workforce shortages, especially through targeted investments in rural and underserved areas. While the digitalization of healthcare holds potential to ease the burden on overstretched healthcare professionals, poorly designed or poorly implemented digital tools can have the opposite effect, adding to their workload and increasing the strain on both healthcare professionals and health systems. When doctors spend excessive time on administrative and data entry tasks, they have less time for patient care. It is therefore essential that digital tools are co-developed with healthcare professionals to ensure they genuinely support rather than complicate clinical practice. To further reduce administrative burdens, governments must ensure adequate funding for the health sector, invest in a well-trained administrative workforce, and work to streamline or eliminate unnecessary paperwork. This allows healthcare professionals to focus on what matters most, caring for patients. Lastly, while tools such as telemedicine can enhance access to care, CPME underlines that face-to-face care remains the gold standard. But our experience is also that follow-up of patients well known to the doctor is a very good use of telemedicine, and also liberates capacity for other tasks. Lasting solutions require more than short-term fixes. They depend on robust health workforce planning built on accurate data and realistic projections. Such planning must aim to achieve conditions which improve quality of care, patient safety, and ensure the accessibility of services. On the note of data, CPME calls on European countries to strengthen health workforce data collection, including on full-time equivalents, to better capture the real workforce capacity. Moreover, national medical associations are also important partners in workforce planning and bring crucial on-the-ground insight in the impact of shortages. The health workforce crisis is a multifaceted crisis which cannot be solved by a siloed approach. CPME advocates for a cross-sectoral EU strategy on the health workforce centered on improving retention, recruitment, and resilience of the healthcare workforce. retaining the existing workforce is essential to ensure sufficient capacity, not only for the future, but also for today. CPME urges EU and national policymakers to improve working conditions and ensure the effective enforcement of existing labor legislation, including rules on working time. CPME also calls for the development of EU-level policies to guide safe staffing levels in order to safeguard high quality and safe patient care while ensuring workforce sustainability and well-being. Strengthening recruitment of doctors and healthcare professionals is equally vital to meet the growing demand for healthcare services. CPME therefore calls on European countries to invest in the development of highly educated and domestically trained healthcare workforce to meet the need of the population. Resilience on international recruitment as a short-term fix for deficit in workforce planning is neither sustainable nor ethical. The WHO Global Code of Practice on the international recruitment of health professionals must be upheld and implemented. We need to uphold high standards in medical education. A lack of adequate numbers of healthcare professionals is not a justified reason to lower qualification and training standards. We need to move away from a just-in-time model to a just-in-case model for funding in the health sector. The just-in-time rationale borrowed from commercial sectors has proven unsuitable for health care. A just-in-case approach is required based on permanent and guaranteed funding that maintains a baseline capacity for universal health coverage and surge capacity for emergencies. This model must accept that to some degree of obsolescence and opportunity costs is the price of preparedness. Efforts to improve the efficiency in healthcare services cannot come at the expense of safety, quality, or professional autonomy. Real reform starts with investing in sufficient numbers of well-trained doctors and protecting the standards of patients that patients deserve. Addressing workforce conditions is the most important primary preventive measure to ensure the well-being of healthcare professionals. So I draw some conclusions. For too long, there has been a lack of political commitment to addressing the root causes of the healthcare workforce crisis. Healthcare is often considered a national responsibility, yet EU laws on medical qualifications and working time already shape how healthcare operates across Europe. With issues like doctor mobility, data collection, and international recruitment extending across borders, European coordination is essential to ensure coherent and effective responses to shared challenges, to also ensure that European countries' workforce shortages do not negatively impact the rest of the world. The warning signs are clear. Europe's health workforce is stretched thinner every year, and it is heading towards a breaking point that will impact patients and professionals alike. These challenges are shared across countries, and so must be the solutions. Thank you very much for your attention.
Thank you very much to Dr. Ole Johan Bach, President of Standing Committee, European Doctors. 非常谢谢欧洲医师执行委员会主席精彩的分享。Thank you very much. All right, our last speaker is Dr. Ki Suk-jum, President of National Health Insurance Service, Korea. He's going to talk to us about National Health Insurance of Korea Strategies in the Aging and Digital Era。那最后一位主讲人呢是韩国国民健康保险公团的郑其硕总裁，要跟我们聊的就是韩国的健保以及高龄化数位时代的相关策略。Ladies and gentlemen, please welcome Dr. Ki-Suk Jun. 掌声欢迎。
Good afternoon. First of all, I'd like to congratulate 30th years of national health insurance in Taiwan. It has been very successful, and I've seen a lot of parameters you have completed, and you have become a leading, first leading country all over the world. And thank again for inviting me to share Korea's national health system introduction and share some knowledges and discuss on it. I'll skip this. I'll show you the overview of our system and some achievement for last nearly 50 years since our insurance began. And there are some challenges, mainly aging population, and some new strategies against it. Maybe it's not new for some others. We have a health security system, and it is a two-layer structure. I've seen several times that Taiwan has covered 99.9%. Excuse me. National health insurance Korea covers 97.2% of whole population, and it includes employees and self-employees, even the dependents. Remain 2.8% of the population is covered by medical aid. So almost all people are covered by national health insurance system. But the remain medical aid, the people who belong to medical aid belong to a same medical care system. Only the funding is different. These are some characteristics of our system. Like Taiwan, we are a single-payer system. National Health Insurance, NHIS, runs both national health insurance and long-term care insurance. Entitlement is mandatory. It's mandatory between NHIS and providers as well. So, and the enrollment is mandatory for all eligible residents, including foreign nationals working or living in Korea. The amount of contribution is based on ability to pay. Mainly, it depends on income, but self-employers, we count the real estates and etc. Even the contribution amount is different, the benefits are all the same. That's to ensure the access to care based on medical needs. And it's a short-term insurance, pay-as-you-go financing, and private provider is dominant. 94% of hospitals and 90% of beds are owned by a private sector. This is a brief national insurance history of ours. We started in 1977, it's 48 years ago, with employees, in companies with 5 or more employees. That was the start of our national health insurance scheme. And in 12 years later, 1989, we have achieved UHC. And in the year 2000, NHIS, where I belong, established. That's merging from 3 different independent insurers. And the year 2008, we started a long-term care insurance. And in 2018, we initiated a contribution system reform, and it's going on. From 2019, we started universal coverage of health screening program. So everyone in Korea is getting a health screening program from infancy to theoretically the end of life. Every other year from 20, and 8 times from infancy to until 6 years old, and during school days as well. And finally, we are on a pilot project for a sickness benefit. Now, let's compare health insurance system between Korea and Taiwan. We have many commonalities, more than I knew when I came to here. I realized that Korea and Taiwan shares a lot of commonalities in terms of health insurance system. We have achieved the UHC in a similar time, and we are single payer, and public funding associated with the private sector dominant is another characteristics. The main difference is we are running a fee-for-service mainly, and you are global budgeting. So maybe we are going to suffer more about the financial stress than compared to yours. The long-term care system is insured based in Korea, but I heard that it's tax-based in Taiwan. What we have achieved during last 50 years was we are quite proud of achieved the UHC in such a short time. Even though we started late, in 1977, we achieved UHC in 12 years. If you look at Germany, they started 1854. They took 127 years to achieve UHC. Taiwan, 45 years. Japan, 36 years. The reason why we have achieved in such a short time is because our income has grown very rapidly. But one of the main characteristics of Koreans are they really do want the equity. They know that they cannot endure inequality, so we were very fast in achieving a UHC. What did we achieve? We had achieved improved accessibility. From the year 1980 until 2022, we had a population of 38 million. And 3 years ago, we had 52 million. It's 1.4 times increase. But if you look at healthcare facilities, it increased 5.7 times, mainly clinics, 71,000 clinics, and 4,000 hospitals. And number of days of hospitalization and outpatient visit is around 20.9. It's 4.3 times increase. It's very easy to go to any kind of outpatient clinic, or it's very easy to admit to any kind of hospital in Korea. As Dr. mentioned, you can go 3 times or 10 times in one day, and we have more than 2,000 people who visit outpatient clinic 365 times a year. So we had some amendment for them. So we have practicing physicians. In 1980, we had 0.5 per 100 inhabitants. It has increased 5.2 times. But still it's quite lower than compared to other developed countries. Regarding long-term care insurance resources, when it started 2008, long-term care insurance, the old population was 5 million, now it's 10 million. And the long-term care facilities increased 3.3 times, while the population increased only 1.8 times. And the beneficiaries increased 6.7 times. Now it's 1 million. That was 3 years ago, a bit less than 1 million. And human resources increased 5 times. So everything increased since we launched both health insurance and the long-term care insurance system. This is to show you enhanced coverage for severe and high-cost disease. Average coverage rate is about 65% for now, but for 4 major severe diseases like cancer, cerebrovascular, and cardio, and rare diseases, the coverage rate is 81%. Top 30 or top 50 severe high-cost disease gain 80% or around 80%. So it's not bad figure, I suppose. And we have improved health outcomes. If you look at the left panel, the life expectancy at birth was 64 in 1977. After almost 50 years, it is 84. If you were born in 2023 in Korea, you are expected to live 84 years. It's a bit higher than OECD average. And it is because it's partly because of a very low infant mortality rate. At the beginning of national insurance, that was 32. Now it's 2.1. It's very low. So we are also defending citizens' health right. For instance, we have an ongoing tobacco litigation effort since 2014. We sued a tobacco company, not only the domestic company, but also Philip Morris and British American Tobacco Company. The litigation value is $38 million US. And we started 11 years ago, and then the last hearing was, this is a second trial, and the last hearing was last May, and we are expecting final decision, final trial coming January next year. So please wish us to win the trial for the sake of a smoke-free world and healthier world. Some others from World Bank and New York Medical College of Medicine wrote about tobacco litigation in Korea in Lancet Regional Health. And luckily, WHO and FTCT sent a letter to support our trial. The challenges are all the same as Taiwan. So it's very interesting. We both countries entered a super-aged country this year. Yeah. We entered the aging society in the year 2000, and just in 25 years, we got very old. Taiwan started in 1994, and Japan started in 1964, and Germany started quite a long time ago and entered a bit ago, but now as many countries are facing aging population. On top of it, live longer, that Korea and Taiwan has both the very same problem. That is, total fertility rate is very low. Korea has 0.73, Taiwan 0.86. So as you know, the number should be 2 if you like to prevent the population shrinks. So in the next slide, you can see the fortune of our Korean population. The leftmost panel, you can see this year's figure. We have 51.7 million population. Nearly 80% is under 65. But in 40 years later, the year 2065, the total population will be shrinked to nearly 40 million, the 10 million deficit, and the proportion of under 65 keeps lowering and lowering. So if you look at the lowermost panel, the population aged 65 and over per 100 people aged 15 to 64, it's a working population. So in the year 2065, one working person should be in charge of elderly one old man or woman. So that's not possible. That's, it is going to be a disaster if you let it go, the low birth rate in Korea. As population grow old, we are expecting health insurance and long-term care insurance expenditure are also exploding. So this year, we have this amount of 75 and 11 billion US dollar. In 25 years later, we have a huge amount of increasing in both health insurance and long-term care insurance. But luckily, we are still remaining in a very low compared to a percentage of GDP. But if you look at, I didn't show the detailed statistics, but if you look at the recent increase of tendency, then we are going to meet financial disaster very soon. So these are the super aged society challenges at hand. As a National Health Insurance Service administrator, we are going to focus on population and health issues. So these are some new strategies. As you know, UN and WHO already proclaimed that about the decade of healthy aging, and it said you have to combat the ageism or create an age-friendly environment. The Korean government, the relevant ministries all together has published policy directions for super-age society, and our organization, NHIS, is making very hardly the impact of super-age society on NICE and future strategies. These are dual strategies in progress in Korea. One is aging in place. It's not a very new one, but we are going to particularly focus on aging in place. And the other one is digital health transformation. To make people age in place in their own house and home, you need to make healthy life expectancy improvement. Because I said it is about 84 years of life expectancy, but if you look at the health life expectancy, it is quite low. So at the moment, we have about 70 years of healthy life expectancy so far. So in order to make people age in place, we need a dementia care, home-based services, and we need to enforce the workforce, and etc. Regarding a digital health transformation, I'll show you later. So aging in place is our utmost current target at the moment. And we had a scheme of NICE PIC. We call NHIS a NICE. Isn't it nice to pronounce that? So NICE PICC, NICE PIC. PIC means promotion of integrated and comprehensive care. So PIC sounds like picking up something, and actually we are going to pick appropriate individuals and make them enroll into appropriate services. So our final target is to make all individuals in medical care and in long-term care and get into their own home and get a community care. I'd like to show you some what I think is up-to-date AI technology used application in healthcare. One is personalized one-stop health management platform, which is called NICE 25-hour. And the other one is work assistance, NICE Mate, and another one is the NICE Call. This is a nice 25-hour. 25-hour means 24 hour and now. So it'll be on the mobile application. We are going to load the medical records, health checkups, and medical services used somewhere like a CT and etc. and long-term care services, etc. So we are going to start this kind of new service from early next year. We have actually a mobile application system now, but we are going to reform some part of it. This is called a nice mate, which means my AI task executor. So this is for our staff to make guidance on checklist for each work step and to facilitate the answering to our customers and making assistance of creating various documents required from internal and external agencies. Finally, this is a nice call. Call means customer service using AI large language model. So we have collected nearly 1 million calls and make them machine learning and speech to text and text to speech technology. We are making this voice bot system, and maybe by the end of this year, we are going to make a service to our customers. We are collecting 37 million calls per year, but still 4 million calls are missing. So even though we are running 1,600 call center steps every day. This is going to be another good service for our customers. So as you know, the robot works 24 hours and 7 days. We are holding a global forum since 2004 every year in the spring. Maybe some of you will come to our institution and our forum. And as you see, Minister Shu has visited our headquarters and had a good time to corresponding each other. Maybe I would like to invite him before my termination of term next year. So I'd like to thank very much for your kind attention. Thank you.
Thank you very much to Dr. Ki-Sak Jung. Yes, please wait on the side for the panel. Thank you once again to Dr. Ki-Sak Jung for walking us through the achievements and also some new and innovative strategies in response to the challenges facing the National Health Insurance Service in Korea. 我们再次谢谢韩国国民健康保险公团的郑其硕总裁精彩的分享哦。All right, ladies and gentlemen, we're going to move on to the panel, and we're currently about 20 minutes behind of our schedule, so probably we'll only do the panel for 10 minutes. We're sorry about that. And for that, we'd like to welcome back our moderator and also 4 speakers to the stage. 那接下来呢，我们综合讨论的时间要再次有请我们的主持人以及4位主讲人回到舞台上。Dr. Liang Yu Chen, Professor Zhi Hong Chen, Ms. Song Mei Zheng, Dr. Ole Johan Bach, and Dr. Ki-Sak Jung. Please take your seats on the stage, all right? Okay, now over to our moderator, Dr. Chen.
Thank you for staying here, and I enjoyed this symposium very, very much. I'm now open to the audience. If there are any questions, please raise your hand, and ask your question, and speak out to the speaker that you would like to ask the question. Please, from Belize, thank you. Yes, yes.
Thank you very much. Must say that it was very interesting presentations. But I have a question for Ms. Cheng. From your observation, if Taiwan was to have been setting up or designing their national health insurance system today, what do you think it would need to change to improve long-term financial viability?
I'm not sure. Oh, okay. Now, thank you for this question. I think that if they were a financing reform is very much needed because they do have a very serious, I would consider it a problem of underfunding that is threatening the equity principle. That is one of the fundamental underlying core principles of the program. So how would you go about fair financing? Right now, the financing is based on collecting premiums, okay? But the premium takes, so the bulk of the national health insurance financial burden is on the salaried, the formal sector employees. And I think that, was it you who mentioned that the corporate sector, which is the service sector, has become very, very important sector of the Taiwan economy. So how do you, and they're not taxed very heavily. Taiwan, like a number of East Asian economies, is a low tax system. Like Singapore, like Hong Kong, etc. And so I think that that needs to change. That the corporate sector, what is their social responsibility versus the salaried class? I think that is really fundamental. Plus, I think that the government contribution to the health care system financing should also consider some additional source of financing. Taiwan has, for example, very low government revenue, tax revenue. So overall, it should reform its tax system so that the government contribution to the health sector can increase. Because right now, it's really amazing. It's 14-point-something% of GDP, the government tax revenue as a percent of GDP is only 14-something. Whereas if you look at the OECD ranking, you know, it's anywhere from the 30s through to the high 40s%. And Taiwan doesn't even, I don't know where it would even fit, it being so low. So there's a lot, I think it goes beyond the healthcare. It's the overall tax system reconsideration, to be fair. And I think that, you know, if as to increasing out-of-pocket spending for to add more revenue to the healthcare system, you can do it as long as it doesn't hurt the less advantaged groups in society. For example, you can do means testing and say that, you know, if a very rich person wants to visit medical centers directly and as many times as he wants, let him do it, but then because the government has also detailed data on personal income tax records, you can look at the income tax reported and say, okay, you're a very high income, so if this is your healthcare behavior, we're gonna make you pay for the added, OOP spending. Yeah, there are ways to do it so that you protect the disadvantaged and yet achieve your policy goal of adding more money to the system.
Kevin, thank you for the question. So May and I talk about this problem, and as you can see from her talk, she's a strong supporter for single-payer system. Yeah, and I do believe that there are some experts sitting in the back. There's a supporter for a mix private, national, insured. So it's an ongoing discussion in Taiwan. Thank you. Any other question, please? Yes. The Minister.
Steve Paterno, U.S. Duke University. On the flip side of revenue generation is cost containment. So this is for any or all of you to comment on. The three main drivers of costs, at least in the U.S., are physician and nurse salaries, but also administrative burden, drug costs, and imaging. How are each of you managing costs, and in how you're managing costs, how does that impact patient care?
This question goes to Dr. Young.
Actually,
Solar system.
actually, it's John, not Young.
Sorry.
It's okay.
John.
Yeah, that. Yes, that's right. Yeah, European pronunciation. We have 16,000 staffs for NHIS, and the administration fee is less than 1%, so it's not bad. The main issue is, as I have already mentioned, is a fee for service. So doctors are doing as much services as possible, and patients are armed with national health insurance plus private insurance. So everybody wants to consume their premium. So the doctors and patients all together are exploiting our finances. So we are going to move to a value-based reimbursement system and etc. But it's not very easy, almost impossible. Maybe some of you know that that the Korean government also increased the doctors' number, and all students and young doctors left the school and left the hospital for more than 1 year. So it's not very easy to reform paying system in Korea. Anyway, the administration is very simple, and we are doing work very hard, working both national health insurance and long-term care insurance, less than 1% of fee.
Thank you. From Swatini, thank you.
Yeah, maybe one last one here. Thank you.
Okay, thank you, Madam Moderator and presenters, for a lovely session. We've benefited a lot. I have one question directed to Professor Chen. Based on the top 10 causes of death in Taiwan, number 10 is suicide. And I want to know if you have done a study or a survey to know the reasons behind. And if you have, what are the remedies or programs put in place to address same? Looking at the public satisfaction survey of +90, I don't think it's a health issue alone. It needs a multi-sectoral approach. Thank you.
Okay, thank you. I think I'm not the right person to answer the question about the suicide, but Dr. Chen, who is a psychiatrist, maybe she can some expert opinion.
Well, thank you. So I was actually the former Director General of Department of Mental Health. So in Taiwan, we started pay for all the psychiatry services from day one of our national health insurance. So first thing first, we do the math. We cover dental and mental health for the first year of our national health insurance. So that's for the severely ill patients, regardless of the psychosis or major depression. But later on, in the past few years, we realized that 70% of the young population, when they have the suicidal behaviors, they did not seek any help. Even though they have the national health insurance, they can go to see a psychiatry or clinical psychologist very easily. So we launched a national program to offer 3 times of free counseling. So they can go there, and then after 1 year, about 10,000 people referred by the psychologist to see a psychiatrist because of their vulnerability and high suicidal risk after 1 year. So increasing suicidal rates in age 15 to 24 is an issue in Korea. in Japan, in Taiwan, in China, in Hong Kong, in Singapore, in a lot of Asian countries. I believe it's almost a global issue. So we are trying our best to battle with that. Another thing is that Professor Chen, he just mentioned in his slide, we are trying to integrate the resources from the community and also in the hospital. So now, so far, we built 56 community mental health centers. We learned the model from Australia. So they did a pretty good job considering the mental health resources investment.
Just one word added. Korea, we have a fourth leading cause of death, the suicide. We did every means to reduce that, but it failed. So we have every institutions, every supporting system, and etc. Maybe it's from a DNA or etc.
Allow me to add a small comment, because everything will be prevented better than cure. So as far as the suicide or psychological problem concerned, we have implemented a social emotional learning program, SEL program, into the school children from this year, because if the school children, they have some SEL program in addition to the academic program, they will behave well, behave better, and they can deal with the conflicts or frustration. So we have also a preventive program for suicide.
Thank you for your questions and discussion and staying all the way till here. And we have later on, I maybe need to sum up here, and thank you for your participation. And thank you for all the speakers who give such a wonderful presentation. Thank you again.
Thank you very much. Please stand up, and Director General Liang Yuchen would like to present certificates of appreciation to all 4 speakers joining us for plenary session 2. 那接下来呢，要有请署长颁发感谢状给我们的所有主讲人。Firstly, to Professor 执宏陈，我们首先呢颁发给国立成功大学陈执宏院长。Thank you so much. And next to Ms. 宗美郑，接下来我们颁发给郑宗美研究员。And next, Dr. Ole Johan Bach, President of Standing Committee of European Doctors. 接下来颁发给欧洲医师执行委员会主席。And Dr. Ki Sak-jung. 接下来我们颁发给韩国国民健康保险公团的郑其硕总裁。Okay, now a group photo. 我们请署长呢站在中间，我们把4位主讲人我们引导到署长的2边，我们一起合照。Okay, let's do one more photo before we wrap up day 1 of Global Health and Welfare Forum in Taiwan. 好，我们再次给台上的主讲人一个掌声。One more round of big applause to all our speakers on the stage. All right, ladies and gentlemen, that's it for the first day of the forum, and thank you very much for your participation. Later, at 6 o'clock, we are going to have a welcome reception. It's on the 3rd floor, the banquet hall. Please bring your badge and join us for dinner. 那各位贵宾，接下来呢，我们6点在3楼的宴会厅呢会有迎宾晚宴，都欢迎各位贵宾呢带着您的识别证哦，踊跃的参加。And for tomorrow, we'll also start from 9:30 in the morning, and it's going to be 2 parallel sessions in the morning. Parallel session 1 here in this room, 101. If you're going to join Parallel Session 2, please go to the 2nd floor, room 201. 那么明天呢，一样是早上9点半就会准时开始哦。2场的平行场次，在我们原场地呢101进行的是平行场次1。那如果要参加平行场次2的贵宾呢，要请您到2楼的201会议室来参与哦。Okay, we'll see you later or tomorrow. Have a good evening, everybody. Thank you.